welcome to the Public Board for Northamptonshire Healthcare this Thursday, 31st of July, and delighted to welcome you all. Just a reminder to all colleagues around the room, our virtual room, that the meeting is being recorded and live streamed. And I particularly want to welcome members of the public who may be observing us today, and indeed any governors, any of our council governors who may be with us. We have apologies from Angela Hillary and Linda Chibutsa, our Chief Nurse. Obviously, David Mayer, as our Deputy Chief Executive and Managing Director, will be representing Angela in her absence, and we are expecting Richard Amponza from Linda's team to join us shortly. I also want to welcome Faisal Hussain. Faisal is the Deputy Chair of our, I like to think, sister trust in Leicestershire Partnership, and part of our group arrangement. Faisal is here observing our board today in public, and in anticipation of taking over the hot seat, if I can describe it, it's just a warm seat in November, and as part of the transition and development programme, we thought it'd be really helpful for Faisal to observe our boards and various other activities. So he's with us today. So huge welcome, Faisal, to you. Okay, I think I've noted all the apologies for absence. Declarations of interest, please, for any items on our agenda today. No, I'll take that as none. So we then have the minutes of our previous meeting, which is the minutes of the 29th of May. I think, Julia, you were in the chair, if I remember, for that meeting. Thank you for chairing the meeting. Is everyone content that the minutes are an accurate representation of our meeting? Yep, great. So we will approve that. So thank you very much. And are there any matters arising that aren't captured on the action sheet? Okay, I'll take that as none. And just on the action sheet, I think we have one action, Richard, just around the annual review of board and committee effectiveness. Do you just want to comment on that at all?
Indeed, Christy. Yes. So we are at the moment just launching, actually, at the end of July, the annual effectiveness review. So we will be picking this up as part of the process, and that will report back through various committee meetings and a board workshop to the board in November. So we will deal with that action through that process.
Great. Thank you. Should we just keep that on at the moment, Richard, until that's concluded and reported back?
Indeed.
Great.
Yes.
Thank you very much. Okay, so we note the update on the action. We also have paper C, which is our forward plan. As far as I can see, all the items are that were due are here. And so unless there's any comments from colleagues around the room, I suggest we just note that. Richard, nothing you want to comment on as far as the forward plan, or Jane? Okay, so we'll note that. Thank you very much. So I'm really delighted to welcome James. Well, I think Linda will, not Linda, Anne will obviously introduce this item as far as the patient story is concerned, but we have made some changes to the way we're managing it. So I'll get Anne to introduce that, and just want to welcome James, I think, who's involved in that as well. So Anne, over to you.
Thank you, Krishni. Yes, a few months ago we were talking about how we just extend our input around the patient story. So we have 4 care delivery pathways: adults, children's, mental health, LDA, and specialist and secured. And what we've asked the pathways to do is to try and bring forward us an example of how the pathway works, to bring some patient experience and connection, and showing co-production with how our staff work. There wasn't an ask to say everything. We want everything to come through that's all good. We want to hear how we develop as a pathway and how we work using our staff and service user experience to inform how we deliver care and meet the needs of our population. So this is the first one, so I'm sure it will develop over time, but James is our Deputy Director of Adult Services, and he's come to share about the adult care delivery pathway this morning. Over to you, James.
Yeah, thanks, Anne, and nice to see all of you and meet some of you that I've not met before, and good to see those of you that I have seen before. As Anne says, we've been ambitious with this, so I'm hoping the technology is going to work. I'm going to attempt to share it now. So just bear with me one moment while I just try and move that into Teams. Hopefully this is going to work. There we go. Can everybody see that?
Yes.
Excellent.
That's good.
Okay, good. Right, I shall make a start then. So, yeah, as Anne says, I'm going to talk to you today about a patient story that affects a couple of our teams, and hopefully show you how through getting patient feedback we can improve those pathways. So before I do that, I'm just going to talk to you a little bit about adult community services. So as you can see in here, we have a wide range of services in the adult pathway, but all of them are fundamentally focused around trying to give people as independent a life in the home environment as we possibly can, whether that journey starts in the home or starts in one of our warded areas. The ambition is the same, and you can see that we have those services split into 4 stacks, and the services we're going to talk about today are in the right 2 that you can see in there. So we're going to talk about community beds, and we're going to talk about one of the specialist therapy services, which is the community therapy service itself. So having just given you a brief overview of adults, I'm going to introduce you in a moment to a chap called Barry, who was one of our patients that I actually met a few months ago on a visit to his home, supported with the community therapy service. And the reason we've chosen to share Barry's story today, because I think this is a really powerful example of how both positive and constructive feedback can be used to enhance the service delivery that we give, and fundamentally impact our ability to deliver better care to the patients. And I hope that's going to come through in what we're talking about. Now, as I said, we've been ambitious with this, and we included some videos. So we've engaged with Barry to film him at home, to ask him for his feedback around how he found his journey. And we have involved Barry in the creation of this. So he's helped collaborate with us, putting these slides together, and talk to you today about his story. So on this slide here, you'll be able to see a bit about the background of Barry's story, and then in a few seconds, the video will play automatically. So this is where Barry arrived at our Hazelwood ward, and then you'll hear him talk about his experience in just a second. So there's some experiences from Barry in terms of his time in our community ward. So before I go into some of that feedback, I'm just going to talk a little bit about how the ward works, and you're going to hear from some of the team from Hazelwood in terms of how that care should operate in the ward. So you can see here that the primary goal for Barry's admission was to maximise that functional independence, basically getting back to a baseline to enable us to get Barry back home living an independent life as possible. And you can see some of the objectives are there, all around movement and strengthening. So being able to get Barry to a position where he could get back home and be independent. And there were some really positive steps made across the 6 weeks that he had it in the ward. So you can see some of those. They were mainly focused around balance improvements or strength improvements, mobility improvements. But what we're going to pick up on as we go through is that didn't necessarily feel like that to Barry in terms of how it actually felt to be on the ward. But before I do that, I'm just going to introduce you to a couple of members of the therapy team from Hazelwood Ward. I'll just give you a little bit more of a background around how the ward actually functions and what they do before I get on to the feedback. So hopefully that just gives a little bit of background around what the experience is supposed to look like. But I think there's some really key feedback here that we took from Barry from his experience. And really this came about because when I was in his home, I went there, as I said, to talk about community therapy services, and he mentioned he'd been in Hazelwood Ward. And I said, oh, how did you find it? And then some of this feedback started to come about. So his main feedback areas really were around mobility limitations. So he felt like he could have walked earlier, and actually that was the restrictions he felt a lack of agency meant that it might have slowed down his recovery. You're going to hear a bit, and I'll summarize at the end, that communication is a fundamental thing. It is in all care, but it really is in this case, and is a really good reminder, because Barry felt confused about why some decisions were being made and what was happening and why. And you saw in the first slide that Barry, arrived in Hazelwood in a difficult state when he first came to us from Kettering. But when I spoke to his wife in the home, she didn't really have a clear understanding of that either. So there were definitely some communication gaps. Barry described limited engagement with doctors, and he said he saw a doctor only once, which left him unclear on his diagnosis and care decisions. And then you heard him talk about the wheelchair challenges he found, but equally, he talked about how at night he found the environment quite noisy and disruptive, and we all know the power of a good night's sleep to be able to make yourself feel good and able to function every day. Well, that's obviously even more important when you're recovering, and therefore that's something that's really, really important. And you'll hear again later on that therefore Barry kind of questioned whether his stay in a community hospital was needed. So his suggestions then for us to think about, and I'll summarize at the end, were increased patient involvement in decisions, enhancing doctor and patient communication, fundamentally to make sure that a patient fully understands what they're there and what that journey looks like going forward, reducing unnecessary restrictions and dynamically assessing a patient. So not assuming anything about a patient, but really trying to understand what that patient wants and how we can impact on their goals and have a positive impact by what their condition is. Improved noise management, as I referenced, and also an explanation, clear explanations for why we're doing the things that we're doing, particularly if people are struggling cognitively or have any visual impairments. So those were some real good lessons and understanding for us from the community inpatient stay. But when Barry was discharged, he was discharged out through to community therapy, which is where, as I said at the beginning, where I encountered him. So this slide just explains a little bit about what that step of the journey looks like. And again, you're going to hear from Barry in a second talking about that. So you can hear from Barry, he's a pretty determined chap, as Barry, about getting his independence back. And he was talking to me about his tins of beans when I was there, and he's he's very proud, as he rightly should be, because working with the community therapy team, he has been able to go from the position you can see at the top of that slide, where he needed assistance to transfer out of a chair or off a bed, to independently moving around his house with the assistance of some things that we put in the home to support him. But fundamentally, he has completed that transition that is what we do for. It's about gaining that functional independence back at home. But you can also see what I mentioned about communication earlier, that if you don't get that right, Barry fundamentally sits at his experience at community inpatients that he didn't need to be there. And if you don't explain that patient journey fully, then you can have that experience. But before I summarize that, just a little bit more on the community therapy service here. So you can see what his goals really were once he got discharged from Hazelwood were around getting home, and his where he was being filmed there is just in his living room, and just outside of there is quite a big step down into his garden, and he used to be out there all the time, out into his garden shed. That's what he really loved to do. And so therefore the goals around mobility and adaptations in the home were all to do with trying to get him back into that space, and he's well on the way to being able to do that. And you can see that the team prescribed these different exercises, mainly around movement again and strengthening, and he really took ownership and agency of that, and you could see his determination to do that really shines through. And fundamentally, by working together with that team, he's been able to basically get to that point. So before I summarize that, then just going to introduce you to a couple of members of the community therapy service who'll just explain a little bit more about their role at the end of this patient journey as their service. So over to them. So in summary then of this case, what Barry's story is fundamentally about is an example of where we can use patient feedback to make things better for future patients. Obviously, we've also had some great successes for Barry in his story, but really using that feedback to understand what it really feels like to be a patient within our services, and then how we can make that better to make the experience better for the hundreds of patients that will be coming through our doors all the time. So to summarize that, these are kind of the next steps that we have taken as a team from directly from the feedback from Barry. So number one is around the empowering of patients. We've talked a little bit about that, but fundamentally, this is a project that we're engaged in around care planning to make sure that we refine how we do this, so that patients fundamentally feel involved in the goals that are set, and that they have agency around what happens. It isn't just, as Barry's example, where he just doesn't really understand what journey we're on and where we're going. That actually that is a collaborative process. That we measure what matters. So we've made some changes to the outcome tool that we use in community beds to make sure that we're measuring the right elements, again in combination with the patient, so that what we're doing is measuring care improvements so that we can fundamentally help get a patient home back into their environment. And then the last three are all around communication in terms of in services, but also so that the continuum of care feels like something that is real. So Barry's experience is he comes from Kettering General, he comes into community inpatients, and then he comes out with community therapy. We want that to feel like one journey, not a bunch of siloed independent services where you have to start again. So what we've done is to get community therapy and community bed therapy teams to work much closer together to share learning, feedback, and celebrate where it works, but also understand where it doesn't so that we can make it better. Linked to that is conducting joint training sessions across the teams, again, to build that relationship between those two teams to facilitate that improvement. And then fundamentally, we're invested in making that transition, that continuum that I talk about, a smoother one by enhancing the handover and communications at the point of discharge, so that at the end, the patient feels like they've been on that smooth journey, they've felt in control of the care that's happening, and they're feeling like that is a positive experience that's got them back to that baseline that they're that we're striving together to make happen. So hopefully that's been a useful exercise in understanding how we use patient feedback and how patient stories like Barry can really help us to make improvements to services, and how this is an example of how we're doing it in these services, but this is the general approach we take right across adults to make sure that where things are great, we learn from it, but equally where things don't go quite as we planned, we can understand what that was about and make changes to make them better in the future. So I will leave it there. Thanks for your time and attention, and I'm happy to take any questions, but I'll stop sharing at this point so I can see everyone on the screen as well. But thanks very much.
Thank you, James. Really interesting and helpful. Now, I'm glad you're happy to take questions, because I know there's always plenty from the board, so I can see hands have gone up. So James, if you're okay, we'll just invite colleagues in turn and see how we get on. So Joanne first, please. And it might be helpful if people haven't met James before, just to make sure that James knows who you are and the role on the board, particularly non-exec colleagues. Thanks.
Hello, James. I'm Joe, Associate Non-Exec on the board. Thank you ever so much. Very, very slick presentation, so congratulations first on the technology. But I think Barry is, the face of our services. He's every man. We have parents, friends, family who Barry represents. And I'm really, really satisfied with the way that patient feedback and the way that you're consuming it and replaying it in terms of what it means for our services, but particularly for those patient-facing teams within the organisation. I think it's absolutely critical. My question is just in terms of the benefit of spreading and sharing this type of approach, because obviously the interplay with your teams are up against the social care, GPs, third sector support agencies. Are they as open to the use of patient feedback to adapt their services? Or are there blockages that you're experiencing?
No, I think generally, I'd have to say that I think patient feedback is the one area where everybody's kind of unified in the importance of it. So I think whenever there are challenges, bringing it back to the patient experience and what they're actually what they're experiencing and what the impact of that is for patients is the one almost unifier. There are other things that can be blockers or barriers between agencies at times, but bringing it back to the patient experience and actually what that means for somebody tends to be the way that we can overcome any of those barriers. And I would say generally, for whatever, it's a challenging environment to work in the NHS. It's very busy all the time, but ultimately the vast majority of people are working in it to make sure that patient care is as good as it can possibly be. So yeah, I would report positively that actually in my experience working with others that taking on board patient feedback is really the thing that promotes us to make things better, because that's what we care about and what matters to us and why we're all here doing what we're doing in the first place. So yeah, I'm encouraged that is what's in place.
Okay, that's gratifying to know. Thank you.
Thank you very much. Judith, please.
Thank you. Good morning, James. My name's Judith Seymour. I'm one of the non-executives. I chair the performance committee. I too really enjoyed the presentation. I think it's wonderful that we can be inclusive with patient stories, because we can do it via video rather than having to have them turn up, which can be quite daunting for some. So thank you for that. I really like yet another example of how NHFT is a learning organisation and is really, trying to ensure that the patient voice is coming through. What I was wondering about is whether it would be possible for you sometime in the future to actually come back and see if it has impacted, positively impacted or impacted our patient feedback. Once the training has flown through the team and it's been embedded, because that's really what we're driving towards here, is that positive outcome that our staff members understand why all these aspects of communicating with patients and making clear why it is that they're there and what they're there to do, why that is important, and then that has a positive impact. Just as a background, I was a carer for 15 years, and I very much hear what Barry had to say. I had to fight quite hard in some instances with some trusts to get information as to exactly what was happening. So no, I very, very much support this, and thank you for sharing with us.
Thank you, and of course, yeah, very happy to do that. And I think that's one of the key things, which is we can put the measures in place, but we need to constantly be assessing whether they've hit the mark, and sometimes they do fully, and sometimes you need to keep tweaking and improving them. So yeah, more than happy to come and update in the future.
Thank you.
Thanks, Judith, and thanks, James. I mean, that might be something, Anne, just to reflect on when we loop round again, actually taking the opportunity to sort of say we were here last time, and these are some of the build the story every time. So that's perhaps just a reflection for us, Anne. But are you happy to come in at the end and we can just pick up any of those sorts of points? Julia, please.
Thanks, Krishni. Morning, James. We know each other. Julia Curtis, one of the non-execs. Great example of a fabulous team with a huge positive impact for people's lives. So yeah, congratulations on the presentation. Absolutely clear and great presentation. I was just wondering about liaison back with the acutes hospitals, because the decision to move somebody to a different setting other than their own home obviously happens at that point. So I just wondered what work we'd done to liaise with them, and actually whether Barry had agreed to share his story so we could share that back with them to hear that too. I don't know, just a question.
Yeah, so the last point, he's definitely agreed to share it here. Whether he's agreed to share it wider, we'd go back and find out. But in terms of the work with the acutes, that is a constant piece of work. So we are constantly engaged in how we improve the processes that we have in place. And one of the elements for that is the decision-making hub of where patients go into. We are looking to strengthen and change based on some patient feedback like this, but also other feedback where patients can often say, I didn't feel like I needed to be here. You heard him talk about, I want a chance. Sometimes the chance is being given a chance to go into a community hospital, but sometimes that chance is being able to go home first, and really having a robust process where you clinically assess how we're making that decision and whether it's the right thing and how the patient voice is brought into it. So I'd say that's an area of continuous improvement, but we have some new initiatives that we're working on for this winter that we've just started. So there's some working groups currently happening across multiple organisations, us involved, but the two acutes involved, social care involved as well, to reshape how we make those decisions to make sure it's as strengthened as we can. And I'm sure once we've done that, that will be a continuous piece of work as well. So yeah, it's stories like this and others that we've used to be able to say, hang on, this didn't feel right, this either took too long or the person didn't feel like they were in the right place. And that helps us to make the decisions better for the future. And a good example, I guess, of how we work across the system to be able to make patient experience and the care that we give better than we're able to at the moment.
Thank you, James. Thanks, Julia. David, please.
Thank you, Krishni. Thanks, James. Really helpful. And I'm always really pleased to see patients using the can of beans and undertaking the exercises and rehabbing. It's always really reassuring. As you talk through a really good patient example, I was also thinking about how important this is for efficient and effective in our Thrive strategy and our way of working. There's a little bit in Barry's story that potentially is a way how we might have been able to reduce the length of stay by mobilising him earlier and taking things forward, which is something for us to pick up. But I also think coming out of Barry's story, something for us to share around the system is the importance of how we've developed and supported Barry in his independence. Because with that independence, he's now better able to look after himself at home. That comes with lower costs for the NHS, lower costs for social care. And I think have a think about, are there ways we can bring that type of conversation out into our system meetings, which really reinforces the importance of doing community rehab well, because it's saving us and others costs in the future. If Barry decompensated so much, the costs would increase. So I think there's an opportunity, and if we can help bring those stories out a bit more, be more than happy to be involved in that.
Yeah, that's a great point, David. That's a really good thing for us to go away and reflect on how we might make that happen. I think, yeah, you're right. I think the fundamental thing I took away, we talk about home first a lot in our system and should do across the NHS generally, but I think you get an experience there of why that happens, because the progress that Barry's been able to make in his home environment where he feels in control and has the agency to make stuff happen has fundamentally transformed the position that he's in, his mobility and his functional independence. So it is a fantastic example of why we talk about home first being so important. You know, Hazelwood, 32 beds in a very small space, and it isn't that the team worked really hard to try and do all those different things, but actually being in the home space is where people can thrive. We see it in so many of our services. So yeah, that is definitely something for us to reflect on about how we bring that forward into those system spaces to really emphasize why that is so important with sort of practical examples. So thank you for that, David.
Yeah, and I mean, it's a really important point, isn't it? Because ultimately it's better for Barry and it's better for the NHS. It's better for everybody, really. It's a better outcome for everybody. And I think it's a really important message, and one that we need to kind of make sure we're clearly reinforcing at every turn, because it's a better patient experience and better for Barry's outcomes. That's two elements, and it is better for services and allows us to care for more people. So I think there's a huge sort of communication piece there for me around how we share that message around the system, really, and with our public, because I think people understanding that collectively is really helpful, because so many families as well need to understand that. I've always said that I have I'm helped by the fact that I have a brother who's a doctor who always said we need to get my mum out of hospital as soon as possible, and that message really stayed with me, but I'm not sure everyone always appreciates that, so it's really important. Duncan, please.
Thank you. James, I'm Duncan Orme. I'm one of the non-execs and chair our audit committee. I also ought to say that in a previous life, I worked in the acute sector at Northampton General and up in Nottingham as a CFO. What a great presentation. And it's really just brought out two things for me to think about, which I'd be really interested in your perspective on. First, the patient story, Barry's story, really clearly showed the impact that a stay in an acute hospital can have on the decompensation on a patient. Really very clear. And we were very aware of this working in the acute sector. I'd be interested in your thoughts on prevention and how we as an organisation can reach more into the acute sector to prevent Barry getting to the state that he wasn't able to stand up on his discharge. And secondly, if I may, I'm very interested in just the richness of the feedback that Barry gave us. But Barry's just one patient. And your thoughts on expanding that so we can get some meaningful patient-reported outcomes from our whole spectrum of patients rather than just one at a time on these kind of events. Thank you, James.
Thanks, Duncan. Yeah, so on the first point then, in terms of our reach into the acutes, that again, similarly is something that we're constantly working on in terms of working with our system partners. One of the projects that we have just started about at the moment is kind of a two-pronged project. One, designed around how we can communicate with acutes around the things that happen before people get to hospital. So the things that we do that are around preventing admissions, and how we can work together to understand the importance of that, because there are loads of our services that are in that space that stop that deconditioning from happening by making sure we don't get them in. And there's a second project which is around the discharge from hospitals. So I mentioned the continuum of care. That also includes partners that aren't in NHFT. So there's a piece of work for us to do around all our services that are even in my own portfolio, but we work closely with mental health as well and children and young people services to make sure that where people cross over into those spaces that we have work. But equally, there needs to be a piece of work around how it does feel like a continuum from the acute into our services, and that acute colleagues understand that deconditioning and how we might work together. So we already do quite a lot of in-reach from some of our services. So we work collaboratively in terms of assessing patients on wards and talking about what we need to be able to help that journey, but it's something we want to strengthen. And what I think is lacking at the moment is a full understanding of all the people that need to understand that in terms of the patient journey, both in the acute and in community services. So that's what that project is all about. So it's already a focus area, but it's something we're really focused on trying to make sure improves, because we know it can have a positive impact. Stories like Barry, it would have made a positive impact as well in terms of Barry understanding and his family understanding the journey before he left the acute, and understand that all the way through, not just when it lands into NHFT services. And then on patient feedback, I think, yeah, that is a really good point. We have methods to collect patient feedback. We have the Equivia service, which we do quite well, and we monitor on a weekly basis in terms of the patient feedback we get back. We monitor what's in it, and we take action in terms of the constructive stuff in there. We also have our PALS service and complaints, but we don't really want it to get just to that point where someone's felt the need to make a complaint before we do it. So part of this is in this learning and this collaboration that I mentioned about between the services is about using these experiences that they hear about on the ground. So in Hazelwood Ward, for example, they wouldn't have known when I was out with the service talking about Barry's story. They were saying, oh yeah, well, we've had this in a couple of other cases. And I said, have we shared that? And there was no mechanism to share that. So what we're trying to do is to try and build those links with key services so that the feedback is coming all the time, that we take responsibility for that. It's not just on a patient to say, oh, I need to tell you this. Actually, we need to facilitate it, make it as easy as possible for patients to do. So they're kind of the two ways that we're doing it. It's an ever ongoing process, but that's some of the ways we're trying to do it, to again give the responsibility back into services. They feel that they're able to do that they can take charge of that, because sometimes services can feel like it's not their place to do it. And for part of my job is to empower people and make sure that they feel that that is their role and that it is part of what they need to do. So yeah, hopefully that explains some of the approach that we're taking in trying to manage that.
Thank you, James. We can come back to patient feedback because I think it's referenced in the quality and safety section of the meeting, because the annual complaints compliments report is in there, and there's some references to the patient feedback system and how we're going to kind of strengthen that. So perhaps we can pick that up. I'm really conscious that we have slightly run over our time on this, but I think that's always a good sign, James, because we're obviously everybody's interested in your presentation and what that has sort of illuminated for us. So I will just get Anne and Itai to make some final comments. I think, Dave, you wanted to come in as well, but if we make some brief comments rather than questions for James, because I suspect you don't have questions for James particularly, but maybe just want to add to some of the commentary. So Anne first, please.
I'm happy to go last, Christian. I'll wrap up all in one go.
Yeah, lovely. Thank you, Itai.
In the interest of time, I will I'll stand down my comments. It was just, you know, to praise the presentation and the hard work that's happening in ICT. So
brilliant. Well, I'm sure James welcomes that comment anyway, Itai. So thank you. So I mean, I think James, it's been really helpful. I think as a first slightly different way of approaching this, I think it's given us a much broader picture of a kind of complete pathway and the interconnectivity within the services with other partners as well. So that's been really helpful. There are some, I think, just one question maybe that Anne could try and perhaps pick up is just whether there can be a broader use of the goal attainment scores was something that was referenced. So I don't know whether Anne or James wants to pick that up, but Anne, over to you.
Yes, I can pick that up. But first of all, just want to thank James. I gave him a task where he couldn't copy what anybody else had done. His first one off. So well done, James. But this really wasn't all about just the adult pathway. It takes a whole organisation to pull this together, and just want to say a massive thanks to our comms team who absolutely supported and got behind the vision of changing how we do the patient story, and it's taken a lot of teams to come around and support, and that's what we want to also show, is that the pathways might be out there delivering at the point of care, but it takes all of us to wrap around to support that journey. So thank you to everybody. I think one of the things that we were hoping is that you will get to see these, because there's 4 pathways, you'll see just over every year, you'll see a couple of times, so that it'll give you a chance to be able to, where we have to bring feedback in. I think we can look at the outcomes question. We've been doing some workshops on how we broaden, how we use sort of measures, and so I think we can bring that back into a future presentation and an update of how we're doing that, because I think it's quite there's something we want to unpackage further, so we will do that in the future, no problem. I think one of the most powerful things that for me is about the home first aspect. I know from doing work in hospitals around many years ago around outflows and thinking about how we do things differently in mental health hospitals. One of the things that, as a community practitioner myself, I found really surprising, but really understandable, that the full extent of people's awareness of what can happen in the home and how powerful it is to see somebody being able to achieve, as Barry did, in his home, because it brings that sense of agency, that sense of control, and there's so much that we can do in people's homes, and I think that's definitely a theme we want to work through, and it's definitely something we talk about in the system meeting, so hopefully we'll see that theme come through in a lot of the stories too.
Thank you very much. So I think as a start of 10, that was a really good example, really enriched the conversation at the board. And I think really also made us think system as well, and how we work together within our own services, but with partners, which I think is really positive. So really welcome that, and what we can do is perhaps just invite board members to make any further comments either at the end of the meeting or separately about any opportunities to develop that the approach further. But as a start of 10, it was a great example. I would just like to finish this story by repeating a line that I often steal from Dave, because he's the one who always who introduced it to me, and I know it's a line from a book, but it's one that I've used repeatedly because I think it really captures it. Health is made at home, hospitals are for repair. And I think I've always loved that line, because I think it really reinforces what we should be striving for, and it's actually very consistent with the 10-year plan and the direction of travel. So really just thought that was a good line on which to end our story. But thank you to Barry James as well and his family for supporting that. And if Barry is comfortable, obviously if we can use the materials to tell that story and share that experience with as many people as possible for the benefit of improving services, I think all the better for the effort that we've put in creating that. So thank you, James, for joining us today.
Thanks, and I will make sure that feedback finds its way back to him and his family as well. Nice to see you all. Thanks very much.
Thanks, Barry.
Bye-bye.
Bye. Right. Thank you, everybody. Really interesting conversation. So we will now move on to our risk section of our agenda, and we go on to risk report, which is paper D.
Thanks very much, Krishni. Good morning, everybody. So as Krishni mentioned, paper D in the pack presents for the board's consideration and hopefully approval the revised board assurance framework and risk appetite statement. Board members will be, of course, well aware that the executive team have been working to identify and assess risks against our new Thrive strategy approved earlier this year. And in most, if not all cases, there's been an opportunity to discuss these revised risks in committee over the last couple of months. We deliberately delayed circulation of this month's report so that we could capture the outcomes of our discussion last week in our development workshop about our revised risk appetite statement, which is, as I mentioned, featured in this month's report. And you can see in the appendix that overall we're minded to be open and indeed eager in some cases to embrace risks for the benefit of improved outcomes. Before I hand over to Christy for questions and comments from board members, it's also worth noting that what isn't in this report is the articulation of those risks that we're going to be managing across the group. So those that refer to group priorities such as digital, research and innovation. When we meet in common with our colleagues at LPT as part of the group board in September, we'll formally then receive the group risks, and so together those group risks and the risks at trust level, if you will, that are included in this report will form the basis of our total board assurance framework for the year. So hopefully it's clear on our approach. As I mentioned, Christy, also in the interest of time, I'll hand back to you for questions or comments from board members. Thank you.
Thank you, Richard. So over to colleagues, if there are any questions or comments regarding either the risk appetite statement, which, as you say, Richard, we spent some time discussing, I think, a couple of weeks ago now, or 10 days ago, or was it last week? The time escapes me now. So we did obviously engage extensively on that, but there may be some questions or comments on the actual detail of the BAF as well. Anything that anyone wants to raise? So Melanie, please.
Right, yes, I thought it was useful just to emphasise as well that these risks obviously get scrutiny at the board committees, and we'll see that in the AAA reports. But I actually had a specific question, probably for Judith in the performance committee, if I may, around BAF2 and the estates, therapeutic environment or estates. And I know that we've got the strategy on the agenda, and I just wondered how or whether Judith could bring some assurance around the rating of 12 as a balanced rating between the challenges that we have, we know, with capital and estates generally, versus the very strong and robust approach we have with maintenance and safety. I point that at you. Sorry, I could also point it at Paul, I should say. Sorry.
Paul, happy for you. Okay, Paul, why don't you go first, and then I'll come in on the assurance piece.
Happy to. Thank you, Melanie. I think it was about 6 months ago. This risk was up at 16 on the basis of where we were with a couple of developments and patients being displaced because we had constrictions around Marina World, for instance. So I think what's changed to sort of bring it back to this balanced view at the moment is we have got some property disposals in our currently underway. We've still got some work to do before we can actually realise them, but nevertheless, that is the direction, as you say, set in the state's 5-year plan. In addition, we're also now back into Marina, which was part of the reason why the scores have escalated. And indeed, we've got more capital than we had this time last year. So we've got significantly more cash available to us to be able to pick up on some of those safety issues that you refer to. So on balance, I think we're okay at the moment, which is exactly what the score says. We do have the propensity, of course, that things change quickly and new risks emerge that we'll have to deal with within the money that we've got. So that's why I think we're at a 12.
Yeah, if I may just come in, Krishni. Absolutely, that is exactly what we heard at Performance Committee. I will be actually addressing the estates plan under the AAA report a bit later in the agenda, but we are the committee hoping that the plan actually comes back and addresses some of the points that I will talk about later on. So this is something that we are at the Performance Committee continuing to talk about, not just once a year or twice a year, because we're sort of aware that estates is actually a really incredible, important part of the jigsaw in relation to innovation, in relation to our value programme, and in relation to service delivery. So yeah, we are actually looking at this very carefully, Melanie.
And if I may just, sorry, Krishni, I think also from the perspective of the service visits that I undertake, and just this week, this week I think it was, I was at the community paediatrics team. And with service visits, estates is nearly always an issue that is raised, capacity, decor, all these kinds of things. And we know it has a tremendous impact on staff wellbeing and the ability to provide good clinical care. It would be great at some point, maybe within the estate strategy and plan, to see some staff feedback and sort of some staff surveying on estates and the level of risk that it provides. I think it would be good to get that perspective on this particular area. Thank you.
Thanks, Melanie. Anne, did you want to come in on that?
Yeah, I was just going to say, I agree, Melanie, and the environment we work in is something that's always often on the top of people's minds when we go in and visit services. I think what's been really great about this process is that we've done a lot of work with ops and estate leads to think about the art of the possible within the money that we have. That's a bit more confirmed now, so it's enabled us to actually start enacting some of these plans, and a lot of that's around how we make the most sensible use of what we have. It's not always you just get a new something, but actually what does it make sense for a pathway, for how teams work, and is it we've often built on. We'll actually taken a whole review. We've looked at the whole estate, and we were really pleased to see this this work come through. I recognise though it takes time, like with anything building wise, to actually see that in reality. So it's kind of how we balance that with services. But I agree, it's something that does come up. But hopefully this will support us responding to that.
Great. Thank you, Anne. Julia, please.
Thanks, Krishni. Just to say thank you for the huge amount of effort that's gone into bringing together a new BAF for our new strategy. So to Richard and to the team and to all our executive colleagues that have inputted and spent hours looking at this, and as a board collectively, we've sort of seen the outputs. So thank you for all the efforts. For me, one of the most important stages is yet to come, which is linking all those operational risks to each of these BAF risks. And I know that on one or two slides we've started that, but I know that's ongoing work, because then in the committees we then look at the detail and bring us as a board collectively the sort of more detailed assurance on each of those BAF risks. So looking forward to that next stage, but a huge thank you for all the efforts so far.
Thank you, Julia. I just wanted to pick up, I mean, obviously it's going to be important for us to just note our endorsement of the risk appetite, which is obviously one of the aspects of this report that we need to pick up. But conscious that in looking at just the summary report, really, there's our current highest risk score state is around the BAF 3, which is our sort of financial in-year financial performance and productivity. I wondered if we could just have some brief assurance around progress with our, I know we'll pick up elements of this, Paul and Dave, in our performance report later, and you may want to reserve any comments till then, but I'm just really conscious that BAF 3 talks about a control gap, which is more worked up, effectively value programme, and I thought it might be helpful for us to momentarily at least reflect on our progress in relation to that, because I think more work was due to be concluded at the end of Q1. So I don't know if either Dave or Paul want to make a comment on that, as it's our highest risk. It feels appropriate that we do that in context of the risk report.
Happy to, Krishni, and we can go into this in a bit more detail, as you say, in the finance section of the IOR. Just so in terms of progress, I think what we still seek is a fully formed, fully forecast value programme, which we're still short of. So we're still searching for 24.4 million, but over the last 4 or 5 weeks, certainly we hit a bit of a plateau in terms of where we'd reached. But over the last 5 weeks or so, we've got forecast delivery of an additional £1 million. So as of yesterday, we were just over 19.2 million for our forecast for the value programme. So again, it creaks forward. Just as a reminder, that is more than we delivered for the whole of last year. So I think that gives you a sense of progress, but I think it also gives you a sense of how difficult this stretch from 5%, which is what we delivered last year, to 6.5% is, and how much of a grind that has been for colleagues throughout the trust. It's become very difficult, and it feels like, as I said, it's much more of a grind to get us onto this stage. So I can give assurance that we continue to move forward. I can't give you assurance that we'll fully get there because we don't have a plan to do that, Krishna. I think that would be my summary at this point.
Thank you. We can come back to that perhaps a little later as well, but obviously useful to note in the context of the highest risk on our current risk on our BAF. Thank you, everybody, and just want to endorse what Julia said. I know it's a team effort to produce the detail for the BAF report, so thank you to colleagues for overseeing that, and indeed the work of the committees scrutinising those risks as well. So we endorse the risk appetite, which is there in the report, and note the current position regarding the BAF, and no doubt we'll pick up some more of those sort of broader discussions around those risks as we move through the meeting. So thank you very much. And was there anything, I know we've got a separate paper on winter plan later in our, I think it's in our confidential board, if I remember, but is there anything you wanted to say at this stage around where we are?
Yeah, so we have had a series of workshops across the system, just working on our winter plan, which is elements of that from the urgent care board is shared through the performance committee on a every time, so that we make sure we keep up to date with where we're at. The winter plan is based on our urgent care strategy and business case, which is in implementation stage at the moment, which is really positive. And NHS England are sort of wanting to see what that plan looks like from lots of different areas, from an organisational level and then from a system level. So we'll discuss it some more later, but the ICB will are then tasked to bring together all those plans to show what the system's doing, and that will go to NHS England at the beginning of September. So we're on a journey of just defining. We've got a good basis, and some of our feedback from NHS England on reviewing last winter is this strategy is a good basis to be building on. So we are confident that we're in mobilisation and getting ready for winter. So happy times ahead. I don't like talking about winter in the summer, but
no, I was just thinking that we are talking about winter in
yeah.
Well, we're not even in August yet. We're still in technically in July, but that is the nature of well, good planning, which is what we're trying to do, isn't it? So so thank you for that update, and appreciate that. So we're going to move on to the strategy section of our agenda, and just want to start by giving Dave an opportunity to highlight anything that's just in our general environment that isn't covered in our chief exec report that will follow, and indeed any comments or updates from the Health and Wellbeing boards, Dave, that you go to. So over to you.
Thanks, Krishna. Maybe if I start with the Health and Wellbeing boards, and then I'll ask David maybe just to comment on some of the Security Services work. So we've just update on the North. I updated on West previously. Councillor Brian Bennyworth is now the chair for North Northamptonshire, and will be joining the Trust Governor, Council of Governors, as a member, just to highlight that for colleagues here. I attended the North Health and Wellbeing Board back on the 10th of July. Helpful to see the SEND action plan come through, and that's a consistent focus of work for the health and wellbeing boards with the priority action plan. We spent quite a bit of time on that, and of course that links to our work on children's services in more detailed form. We also took through the Better Care Fund that was agreed through the Health and Wellbeing Board, and that has an impact on us as a trust because we provide some of the services within the Better Care Fund, particularly some of the services that James described earlier during his presentation. And then finally, just to note that both the dental plan was agreed through the Health and Wellbeing Board, both at North and West. That's a plan that's developed by the ICB, and of course our patients have an interest in that, not least because we provide or have been providing some of the intermediate oral services. And the joint strategic needs assessment for pharmaceutical services also went through the Health and Wellbeing Board, and that of course is of interest to us too, considering our interface with those clinical pathways. So that's just an update on the Health and Wellbeing Boards, and I attend those on behalf of the Trust. In terms of service visits, I won't draw out any particular highlights, Christian, but maybe just highlight to board members that we're now in a much more detailed way looking at services that don't get many visits from us because they are smaller or are part of bigger services, and we'll be looking to our EMB, our Exec Management Board membership, to help us make sure we've got wide distribution across all our services across the Trust. So that's a welcome addition, I think, to being able to funnel the voice of teams through our executive structures and then up through here into the board. But I don't have anything particular to flag for the board in terms of service visits at this point, other than that improvement to the methodology. We've had some work with Loudon Grange, as colleagues would be aware. It's detailed in the Chief Executive's report. I'll just ask David Williams, just to, I've lost him on my screen. He's come off mute. Thanks, David.
No problem. So HMP Loudon Grange is a prison in Nottinghamshire holding about 900 men, and we were mobilising, so we transferred the healthcare responsibilities from Nottinghamshire Healthcare to ourselves on 16th of July. In terms of making that work and building that all through, there's a couple of sort of complicated pieces of governance that all went well. So transferring the CQC registration from Nottinghamshire to NHFT ourselves kind of does need to flow through with a sort of an immediate switch at around about midnight. So that worked through, and we also need a Home Office controlled drugs license for the provision of services, and again they both migrated through perfectly well. Mobilisation went well. 39 staff have now 2P'd across into NHFT from HMP Loudon Grange. In terms of just assurance around the due diligence on that, everybody's professional checks have now been completed. So we know that everybody who's a nurse who's come across to us is a qualified, competent, registered nurse, and for all the other professions that work through. And everybody who's also moved across to us on 16th of July has been paid at the end of July. So those are the important bits about ensuring delivery, making sure things work. We go down through a period of stabilisation now, understand the service, work it through before then starting the transformation. Our next move is scheduled for HMP Ramby on the 1st of October. What we have done following some of the learning at HMP Loudon Grange is we were going to mobilise all 4 Lincolnshire sites on the same date, but we've reflected that that provides a greater challenge about spreading our capacity, particularly around IT support, to make sure it goes. If we need all our IT support to be in 4 locations all at the same time, that makes it a little bit thinner. So we're agreeing with NHS England, with the CQC and with Notts Healthcare to spread those mobilisations out a little bit more in Lincolnshire in order to make sure that actually the implementation goes smoother. And the last thing I was going to say is weekly mobilisation meetings continue. Execs continue to receive updates on a weekly basis, and a formal paper goes into our strategic exec board on a monthly basis.
Thanks, David. And Christy, then finally, if I could just ask Anne and or Itai to just give us a brief update on industrial action, which of course is something that's progressed since we last met as a board. It is detailed in the paper as something that was happening. Itai?
Yeah, I'm pleased to report that we had no serious incidents during industrial action due to absence, junior doctor absences. I'm sorry, I should be saying resident doctor absences instead of junior doctors, because that's the new nomenclature. The absence was due to a mixture of annual leave and some of the resident doctors choosing to go on industrial action. So there was 19 of them on annual leave out of the 40, and there were a few who were also on strike. We managed to cover all our rotas, and so we managed to do that, and we had backup plans for everything. All the clinics that needed resident doctors to go into them were cancelled, and the patients informed, and we have made contingency plans to have those patients seen as soon as possible. So that's the update.
Okay, thank you, Ty. Anne, did you want to make any comments at all on that?
Yeah, just echo Itai's words. They did an extremely great planning piece, and that really paid off, because striking at this point of the year is very difficult. It's been challenging across the system. I think we were in as good a place as we could be, but it has obviously impacted our colleagues as well. So that flow of patients is challenging as we come back to normal and sort of work through the recovery. But Itai and team's work put us in a really strong position. So thank you to the doctors for that.
Thank you very much. Dave, is that everything you wanted to cover? I'll bring you back in shortly, obviously for the Chief Executive's report. As you mentioned, Councillor Bennyworth, I was just going to mention, I believe I'm meeting with Councillor Bennyworth this week. I think it may be tomorrow, because both Councillor Bennyworth and Councillor Course, Laura Course, I think, is the nominee from the West, are going to be our partner governor representatives from the two councils. So I had a very positive and engaging conversation with Councillor Course last week, I think it was, as part of her induction. And she's very keen to visit some of our services, and look forward to connecting with Councillor Bennyworth as well. So just wanted to mention that. Also thought it might be useful to mention to colleagues that we've agreed that next week's council meeting, it is next week, isn't it, Richard? Next Thursday, Julia is going to be chairing the council in my absence, but we are going to focus on the service visits process. So just wanted to pick up that, because we thought actually the development of that process and the reporting and the theming of that was a really good process to describe to governors, and also to encourage governors obviously to join service visits as well. So just thought that might be helpful just to mention in the context of the discussion we've had. So thank you, Dave, for the update, and thank you to colleagues who added to that. We'll move on then to the chair's report to the board, which is paper E. I'll take the report as read. So really, obviously we've welcomed Faisal already. The report refers to Faisal being announced as the interim chair from the 1st of November, and obviously he's observing our board today. But I also wanted to draw the board's attention to the arrangements for our annual public and members meeting, which is obviously a really important event for us and for our Council of Governors, who have been active in shaping the event with our support. And the date for that is Monday, the 15th of September at 5:30. So I'd obviously be very grateful if board members could make sure they are able to join that meeting. There's a big focus on the new Thrive strategy, as you would expect. And as ever, there will be service-related stories and governors outlining their own experiences of fulfilling their pledges, etc. So it should be a great event, as it always is. So just wanted to take the opportunity to highlight that, and also to mention, important, I think, to note in public that there was a submission due by the end of June for the fit and proper persons checks for all board members, and we submitted in line with the deadline. That went to colleagues, would have gone to colleagues in the region for review. We are awaiting the outcome of that. We normally get formal confirmation that's been reviewed and they're satisfied with our submission, but it did meet the requirement, which I just wanted to highlight. So are there any NED colleagues who want to highlight anything that they were involved in? Actually, before so I'll invite you in a moment, but I also want to mention Dave and I were at the Long Service Awards event, which was a really lovely event. We had a number of colleagues who, I think some colleagues who'd worked for the NHS for over 40 years were involved in that event. So it was really powerful. Many colleagues shared their stories and their experiences of working with the organisation and the wider NHS. So always a lovely occasion to celebrate that. Just want to invite NED colleagues, if they want to come in to highlight anything that's was in their activities for the last couple of months. Melanie?
Yes, well, if you wouldn't mind, I just wanted to circle back round to my visit with ITI to community paediatrics on Monday. I think it actually says CAMS in the service visit report, but I just wanted to say it's a fascinating service, clearly covering a whole range of care for children, and I was just so impressed by the attitude of the staff towards trying to find innovative, more efficient, better value ways of providing the services, particularly in terms of coordinating across both other sort of services within NHFT, but also across schools and the independent sector and charities. And a huge just energy and commitment towards the children, and a real resilience, I think, in terms of, as we know, some of the increasing demand and acuity, and particularly areas like ADHD and medication, and so many areas in which they are trying to increase capacity and drive an even better patient experience. Just a really inspiring visit, and ITI's writing up the notes, incidentally. But yeah, a really good visit.
Great, thanks, Melanie. And I can see that Robin wants to come in. So, Robin?
Yeah, I was just going to say that I attended a recent clinical audit celebration day, which was held really as a kind of reinvigoration of clinical audits organisation within the trust, very much led by ITI. And this really did assure me that there was a really committed engagement with the clinical audit process, which enables so much assurance in itself that clinical quality is of high standard. What I saw was a very healthy programme delivering very good contributions towards outcomes and patient safety, involving staff from all disciplines, medicine, pharmacy, nursing, whatever. So I'd just like to highlight that and ITI's support for that programme.
Great, thank you very much, Robin. Really useful to hear that feedback, because it's, as you say, I think that's probably the first time in a while, isn't it, ITI, that we've had one of those days, or was that something that you had done regularly in the past?
No. So I think over the past 5 years we've been working to build the clinical audit team, and we wanted to have this event, and it's the first time that we've held it since I became CMO. We wanted to have this event just to encourage people to engage in clinical audit. and also to encourage people to, work collaboratively with other spaces such as research and innovation, quality improvement, as part of that whole cycle of continuous improvement. And what was interesting about that is that, some of the audits that were presented were forerunners to, more detailed pieces of quality improvement work. And I think just celebrating those events brought wider awareness. Some of the individuals who presented audit projects were pleasantly surprised when they won, because they didn't think that some of the audit projects that they had done had wider implications across the trust. But it was so interesting to see that one audit, which someone thought was, only specific for their area, very rapidly became, spread like wildfire, because lots of people wanted to replicate that to improve patient experience. So I think it will be a regular feature, and, we're hoping to do an even bigger event next year.
Brilliant. Thank you, Itai. That's a really additional, kind of rich additional feedback as well. And I think it shows the value actually of celebrating success, because I think it really reinforces and allows sort of sharing of learning and actually encourages others, I think, to think about how they can take initiatives forward. So really good. Thank you very much, everybody. So we'll note my report. Move on, Dave, to the Chief Exec's report, if there's anything you want to highlight from that.
Thanks, Krishni. There's quite a bit of detail in this month's Chief Exec report, so encourage and take it as read. I guess just to call out the Fit for the Future piece of work, which we trailed through board previously about the 10-year plan for the NHS. That's now been published, and helpful also, David and I, exec team colleagues, were reflecting to coincide, not by design, with our Thrive strategy across the group, because it now gives us an opportunity to take the national framework and then build that into what we're trying to achieve locally through NHFT and as a group with Leicester Partnership Trust. So that's just a really helpful kind of bit of context. The National Neighbourhood Implementation Programme has also been launched, and this plays to the conversation we had with James about neighbourhoods and the value of working closer to people's communities and closer to their homes. We're obviously really keen to develop that locally. We're taking a bit of a leadership in some of that work and some of the thinking. David Williams has been involved. We have agreed as a system to begin to move towards a neighbourhood way of working with map to the local area partnerships within the 2 local authority geographies. And again, just to update members who are watching the board, that we have already been working in this configuration for some time. Our mental health teams, as an example, have been doing some good work aligned to neighbourhoods, certainly for the last 12 months. Also, just to note, Angela is involved in a national working group in relation to some of the ambitions in the 10-year plan about integrated health organisations becoming a framework. So again, important that as a sector, mental health is represented, mental health and of course community is represented in some of those large strategic pieces of work. So again, helpful to have Angela's input on those. We've got the Freedom to Speak Up annual report on the agenda, just to reflect the safety updates from Penny Dash. We of course are continuing with Freedom to Speak Up as a major part of our ability to listen to our teams and our colleagues when they have concerns. So whilst there's a mooted change to the National Freedom to Speak Up office, that does not change the framework we are applying locally, just to reassure. Also, just to update, as it will form part of the board's governance and oversight, the NHS oversight framework has been published, or is in development rather. It's still being finalised for national publication, but we know the things that it is measuring, and we are able to establish where we have areas of improvement across the trust, which we will bring through in future performance reports as per our plans in that respect. The other thing, just to pull out, Christian, if I could, we've touched on industrial action, but the CQC appointments are detailed in the pack, and we're really positive about The appointment of Bola in the Chief Inspector of Primary and Community Services brings a real inequalities lens to some of the work in that space. And equally, we have met as a Midlands Leadership Chief Executive Network and Deputy Chief Executive Network with Aaron Chopra, who's the Chief Inspector of Mental Health, who Itai is a contemporary of Itai's. And we had a good, open, frank discussion with the challenges the sector faces with him in the last 2 weeks, which again sets a positive tone in terms of our ability to meet regulator expectations. I'll just give an update on ADHD very quickly, if I may, because it features predominantly in concerns fed back from our residents, and it features strongly in our performance reporting about challenges we're facing meeting the needs of that community. Just update on the National Task Force. They have now published an outline draft report. They're working to complete a final report later in 2025. They recognise that there is a need for timely access to needs-based support, and they also have helpfully clarified that we're not seeing an increase in prevalence necessarily. What we are seeing is a greater articulation of need and a reduced level of stigma, that people feel more able to describe the needs they have. We will be working with them closely, of course, to see ways of innovating and improving through our 26-27 planning process. But needless to say, we would be looking very much at local neighbourhood-based resources to support innovation in that space. And then obviously our role as a specialist provider being something that we can then target to those with more complex needs. So more to come on that, but a helpful bit of movement nationally. Then in terms of we've covered the long service bits. Also, we've got a new symptom checker, just to highlight that, in our MSK services, which again is moving us closer to some of the innovation that's happening through AI and others across the pathways that we have most struggled with, which MSK is one of them, which we're now finally getting a bit on top of in terms of waiting lists. And just to celebrate the NHFT magazine, which is linked in the paper. And I'll just finalise with just some good news about colleagues. The Joanne Fitzgerald, who's our Deputy Hotel Services Manager, has been named Public Sector Catering Manager of the Year, which of course we're very proud of. And at the Governors' meeting that we had this week, I've forgotten which day exactly, but there was good feedback in our group, Krishni, about people who use our services are really, really positive about the food and the quality of our facilities. So it's really fantastic then to see that recognised nationally in awards for colleagues. So yeah, just it triangulates the information and gives us some confidence that we're doing the right things in the right way for the right reasons. And then also Kerry Healy, who also works in our services, was in the finalists in the Chef of the Year award on a long run, I have to say, of NHFT hotel services colleagues who are getting into national competitions. So again, really proud of them and pleased to be able to recognise them here. And then finally, just to recognise Ian Graham, who's been a long-standing trust clinician and colleague, who's also one of the RCN reps, has been named Steward of the Year for 2025. And that is lovely for Ian because he's been with the trust for so long, but I know he's also looking to do other things as life moves on for him. So a lovely recognition that he gets that through from his Royal College at this stage in his career. So many thanks and well done to him for everything he's done. That's it, Krishni. Have good questions.
Thank you, Dave. Lots of rich content in that report, I think, and not least the recognition for all our staff or colleagues, but specifically who've contributed or been recognised nationally. Any questions or comments? Dave, interestingly, your hand has gone up again, so I don't know whether you wanted to come back in. Is there something you've missed?
Yeah, no, as I wanted to finish on a positive note, I just wanted to make sure colleagues are aware that our workforce implementation plan for 25-26 continues. Part of that implementation required us to look at developing a mutually agreed resignation scheme, which is detailed in the paper, which we're now concluding this week. We'll be reviewing the applications for that, and hopefully that will make a contribution to delivery of our workforce plan for 25-26, but we'll keep Performance Committee and others updated on progress, People Committee specifically on progress with that over the coming months. But just to update people on that here, because it is a significant kind of milestone. It's been agreed nationally too, just to reflect that. So the national team have signed off the process. We just want to get logged here through the board also. Thanks, Krishna.
Thank you, Dave. So any questions or comments before we move on? As I said, a lot of rich content. I will just make a brief comment just on our catering. I think you highlighted, Dave, the catering, and actually that was very evident at the Long Service Awards. The catering was absolutely amazing, and I actually wanted to make a link to the Green Plan because I don't know if anyone picked up that the food waste initiative around creating onion bhajis from food waste, and actually we had that at the Long Service Awards. So I just wanted to mention that and the whole catering experience was amazing, and the consideration for staff and also the consideration for sustainability was evident, and I just thought it was amazing. So I was going to pick that out. It's only a small thing, but it's just actually experiencing the reality of these things on the ground is really important. It's not just something we aspire to. So thank you. So we note the Chief Executive's report and hand over to Paul for the estates plan, please.
Yeah, thank you, Krishni. It's good to hear, but the Green Plan is next, isn't it? So just as far as the estates 5-year plan is concerned, we said when we signed this off as a board over 18 months or so ago now that we would come back and just make sure everything was still relevant, give it a refresh if required. So it's just to reiterate where we're at. There's no huge changes to what we've already signed off as board, as I said, about 18 months or so ago, but it is key as far as the conversation that we started earlier in the meeting around BAF2 and about how we deliver our therapeutic environments. I should reiterate that there are a couple of things that have changed since we originally signed this off. So the ICB's infrastructure plan was done after we signed off where we were at. So it's just about making sure that we honed what we'd got to the ICB plan, which it does. And so there's no huge change as far as that's concerned. A key feature of the original plan and remains so is about the disposal of properties, whether those that we own or whether it's through partners such as NHS Property Services. But that's still a key feature of what we plan to do, particularly over the next 9 or 12 months. We've got 2 or 3 sites that we want to dispose of completely, which will reduce how much we need to spend to maintain those. We have reviewed the 5-year plan, and so this paper confirms that it does remain relevant and factual, but it's also given us the opportunity to bring it up to date for the new Thrive strategy as well. So I hope that's welcomed. And what I would suggest, Krishni, is that subject to everyone being happy with where we're at, is that we carry out further review sort of this time next year in order to make sure that we keep on and up to date with the latest movements that we've got. So happy to take any questions at that point.
Thank you, Paul. Any comments or questions relating to this? So yeah, there's a few hands coming up. Let me just check who wants to come in. So Joe first, please.
Thank you. Thanks, Paul. The only sort of comment I would add to this, I was going to make a point about the Green Plan and sustainability, but you just put her hand up, so I'll leave that for her to discuss. But the obviously the shift towards neighbourhood models of working, I think may in future give us some pause for thought on some of the details in the 5-year plan, and obviously board at that point, I guess, would take a refreshed view. But yeah, I'll leave it at that. Thanks, Paul.
Thanks, Joe. Good point.
just pick up on that. Exactly right, Joe. And as Anne said, when we were talking about the risk paper, that needs to be driven by what services we deliver from where, and so clinically and operationally delivered. And essentially, the estate's arm of that is just trying to deliver on what we need to do. The good thing for us, I think, as an HFT, is that as a community provider anyway, an awful lot of what we do is out there in the community and in the neighbourhood working. So you're right, we do need to refresh it once we get those plans a bit more refined.
And I think a critical point for me, Paul, is that the estate strategy is enabling that adjustment to the way that we deliver services. Thank you.
Yeah, really important point, Joe. Thank you. Tim?
Yeah, just to build really on Joanne's comments actually about this neighbourhood working. And I like the fact we're looking at one public estate and we're talking to PCNs. My experience of primary care, though, is that they are very, they don't have the capacity or capability quite often to do this sort of estate planning. And actually, I do wonder if there's something we can do collaboratively and actually offer more help to them, because I suspect there's more upside for us and will help them as well. I just think there's a big brother thing here working with very small surgeries, and I think there's probably more we could do collaboratively. That's the first point. And the second one was going to be the green agenda, but Judith's got a hand up and I've been told to step away.
Can I get in there, Krishna, to on that point? I'm now dreading Judith asking me a question about the green. Tim, you're absolutely right. I think where we can, I think there are all sorts of conversations going on with ICB sort of scaling down what they do, and in this space, I agree with you. I wonder whether we can step into the space that you're describing in a much more collaborative, co-produced way with PCNs about how we can lean in to help each other. Quite often, particularly on the outskirts of the county, we just need somewhere that we can drop down a health visitor or district nurse or that really within PCNs is incredibly valuable to us, but there will be some of this high level planning that we can certainly help with PCNs. Absolutely.
Yeah, really good point. Thank you. Thank you, Tim. Judith.
Thank you. I love how both Joe and Tim sort of preempted my hand. That's quite amazing. I don't know how that happened. Paul, I mean, as you recall, we had quite a long discussion around the estates plan at the last performance committee, and as you know, the committee decided not to rate the report because we felt that we wanted the report to come back for further discussion. And the question is very much around understanding more in detail as to how the estate strategy aligns with our Thrive strategy, i.e. where are we investing in relation to estates where we need to provide more estate for services, and where are we where potentially the gaps are, but also what are we drawing back from. So more of a nuanced understanding of the plan itself is what I think we would prefer to have a performance committee. So I'm not sure if you can address that right now, but it's just something that I'm also highlighting from performance committee AAA a bit later.
Yeah, if I can try, Krishna, at least to deal with that. I think there's a number of factors that all sort of cross over here, don't they? And you, in your question, you allude to that. So for me at the moment, it's not necessarily about more buildings, more estate. It's actually about less, and it's about reducing our estate. That has a positive knock-on to our reducing our emissions, fewer buildings, fewer energy usage, and so on. That means that we're contributing to the green plan as well in that sense. There's also the financial overlap as well, Judy, about, as I said, if we've got fewer buildings, we are spending less on energy. We are also spending less on maintenance and rent and so on. And actually, for the disposals that we've got in the pipeline, they are properties that we own. So we can bank a capital receipt as well, which gives us a small win, which means that we can use those for investments back into delivering some of the initiatives that we might have through the Green Plan. So there's a whole sort of Rubik's Cube there, isn't there? But I think they are all aligning as where I would describe. That said, when we get onto the next agenda item, I was going to finish my sort of opening, Krishni, with, but I think there's much more that we can do in this space. And so I'll kind of leave it now.
Okay. Thanks, Paul. I certainly look forward to the further conversation on that. Thank you.
Thank you. I mean, I think, you know, it feels like this is it's very difficult to fix this. It's more, you know, I've been lately kind of feeling like the tectonic plates around the NHS are moving and shifting, and there is a sort of bit of a sense that, you know, we just need to find, so Joe rightly raised kind of the neighbourhood health service developments. Tim, I think, rightly raised, you know, how can we work with primary care? All these are things that they're not fixed at the moment, are they? They're things we need to be agile to and adjust to and be able to take advantage of opportunities that arise. And I think I mean, we touched on one public estate earlier. It's really about optimising that collectively, because we definitely don't want to open new buildings unless we absolutely have to, and therefore how do we maximize what we've got? So, and I think Anne touched on this even within our own services earlier, you know, we are financially constrained and capital is limited, so how do we make sure we've got an estate that is capable of delivering the kind of environment within the resources we have? How do we maximize it? And that seems to me the kind of the way of working that we need is to be constantly reviewing and adjusting to make sure we're meeting those needs. Just because at the moment the strategic context doesn't feel wholly settled, if I can sort of describe that. I mean, I think we know what all the pieces are, but they haven't all landed. You know, we know what a strategic commissioner is trying to be, but the design of those organisations that is not yet completed. The design of neighbourhood health services isn't completed. So all of that work, I think, needs to inform our bigger pieces like this, and we need to be agile to that. That feels to me important, really, in the context of where we are. So undoubtedly, there will be a need for further conversations as we adapt to that, I'm sure. Melanie.
Yeah, I just wanted to circle back round to a point that Tim made. I think a lack of expertise and skill set and capacity, because so much of our strategy, but then everyone else's strategy is intertwined. I think there is a real need for leadership, maybe at ICB level, that actually lends capacity and capability across the provider landscape. And the challenge, of course, as you've outlined, Krishni, is that everything is moving, and there's a real danger that nothing happens as a result of everything moving, whereas there is obviously stuff that we can be getting on with. I note in the strategy the reference to the annual estates plan, and I'm sure that that's coming to performance committee, and that, you know, at least some momentum and some movement can be driven forward, because we know it's so critical. Thank you.
Thank you, Melanie. David?
I was just going to say, one of the work programs that the ICB have got at the moment is about understanding how they will transfer functions, responsibilities and ways of working. So we've had an initial meeting with representatives from both across the cluster ICB, so LNR and Northants met with myself and a colleague from UHL, and we started to map out what would be the things that providers could take on, how would things change in a model. And so as that starts to develop, we'll then bring that back for board conversations and other approval. I don't think it will be fast. I think the bigger changes in the ICB will take into the next financial year. But as we map that out a bit more, we'll bring that back to board for a bit more of a conversation about the way forward.
Thank you, David. So I'm conscious, you know, I think people have made a number of really good points, which I think we just need to kind of note and recognise, as we've already said. Just the practicalities then, Paul. clearly you're asking us to approve the updated strategy, which I think we're happy to do. There is just 2 questions really. One is there an annual plan that's then going to performance that's falling out of that? I think we have had an annual plan, I seem to recall before, so perhaps just if you could respond to that. And you also mentioned in the covering paper the expectation that we're going to have to refresh again in the spring, summer of next year. So I probably just want to note that really as much as anything that we would probably have to keep this coming back to board really in a year's time. So Paul, any final comments in respect of that?
Just in reverse then, Christian, I think with any 5-year plan, as we've talked about, things change. Things are changing as you described. So absolutely, we will keep this under review. I think what I wanted to make sure I came back through here was that we didn't, as a board, approve a 5-year plan way back then, and it just sits there until it gets refreshed to another 5 years. So absolutely come back and pick up the comments that people have already made. And yes, in terms of, sorry, Christian, what was the first element? Was around the annual plan. So we did have the annual plan at Performance Committee recently. There was a bit more detail that colleagues had requested, so we will make sure that that is serviced through Performance Committee that's already been requested.
Yes, thank you, Paul. That's a good reminder. I think we agreed it would go through performance and the strategy refresh would come through here. So we'll wait, Judith, for any kind of updates you want to provide through performance. Good. Thank you very much, everybody. We move on then finally to paper H. So back to Paul on the green plan.
Yeah, thank you, Christian. So this is more of a rewrite than a refresh. So there was new guidance that was released by NHS England back in February, and it talked about all providers needing to rewrite their green plan. The current one that we've got was to run from 22 to 25, so we were due to do that anyway. We have refreshed everything in terms of the plan, but also a much more of a focus this time from us on how we take it through the governance. I think sometimes that has been something that we've been intermittent with about where it's appeared and our progress against the green plan. It was refreshed in 21-22, but of course that was in the midst of the pandemic, and I think it just didn't get to the top of enough agendas enough times. So we've put the new plan together. We talk about the aspects in the chapters which will be familiar from the previous green plan, so they still remain, and it still essentially is to try and take us through to prioritise interventions and look at population health. And again, it really chimes with the 10-year plan. So in that respect, I don't think there's anything new as far as this is concerned. It's very much our strategic approach, but it does pick up some of the achievements that we've had previously. So we, continual transition to digital communications. Again, we continue to build on that within the 10-year plan. 95% above 95% of our lighting across the estate is now LED, which sounds really small, and inevitably is. It costs quite a bit of money to be able to do for a trust and an estate of our size, as you can imagine. But again, that cuts down considerably our energy usage across the site, across our sites. So just a couple of final points. The whole green plan has been developed with engagement with staff across the clinical and operational teams. It's gathered through a number of interviews and group work. So this isn't and hasn't been developed in a dark room, essentially. And it's also being done at the same time that the Thrive strategy was emerging. So again, that's been built into it. There's quite a bit, as I said at the end of the previous item, there's quite a lot in here, and how we monitor it going forward. We're setting up in partnership with LPT a delivery arm, and that will bring together key owners of the chapters from across both trusts together in the same meeting to be able to monitor progress. I've talked before at board and in committee about as a trust we don't have any dedicated support, and we've now changed that. And thankfully, David was generous enough to offer up Amanda from the strategy and partnership team, and she has transformed and revolutionised my thinking on this, and we've become much more proactive in the space around this, which is I think we'll start to see fruit as we go through to the remainder of this year. We will also start to bear fruit sometime next summer once the orchard is up and running. We've got the trees on order. We'll get them delivered next spring to sites across NHFT and LPT, and that means that we are planting somewhere in the region of about 100 trees across the two trusts. And seeing as we were planting trees, I thought, why not make them fruit trees and make use of them? So again, that point you make, Christian, about food waste, well, we'll generate our own food and use those in a way that the catering staff can benefit from, as well as our patients and our staff. So there's much more that we can be doing, but the plan, I think, sets out is a much better plan than we had 3 years ago. There's lots more projects that are on the go. But as I said, I'm sure that the subject matter that we've got is almost never ending. So the overlap with social value, for instance, which we've talked about before, is something that we can deepen as well. So happy to take any questions at that point.
Thank you, Paul. I was going to dare to ask about the orchard because you and I have spoken about NHS Forest and the trees. I think it's really, it might feel like a small thing, but this is partly about us being an anchor institution as well, isn't it? And actually, I remember going some years ago now to a sustainability, when we had the SDU, Paul, which was a while ago, the Sustainable Development Unit. I was actually one of the people who regularly went to their meetings, but I think there was a group of chairs and non-executives involved in that. And we were talking about planting trees and how do we use that for the community, but how do the community benefit from our green spaces? So I think there are some really interesting opportunities around this. I'm really pleased that you referenced that because it's a small passion of mine.
I'll get you back, Christian, to plant the first one.
Okay. Judith.
Thanks, Krishni, and thanks, Paul, for presenting it. This is the report was already discussed at Performance Committee and a Performance Committee workshop. And we really welcomed the detail and the thought that has gone into this report. I know that Paul and I have spoken about the Green Plan and refreshing the Green Plan for a while, because it is something that I find very close to my heart. It's an important aspect of the work that we do. So I really welcome this report. It was really supported at Performance Committee, and also we really welcome the resource because that's sort of what it needed to really push it forward and to produce a report that is actually very well rounded. So thank you.
Thank you, Judith. And Richard, I think this is one of the BAF areas that we will be looking at together at group. I know Paul just referenced kind of group element to this, but I think that's right, isn't it? It's yes. Certainly sustainability has been a topic within the joint working group previously, and therefore it makes sense to continue that jointly because of the opportunities that might present. So thank you very much for the work on this. I think we can see that it's been obviously positively received at the Performance Committee, and a lot of assurance was taken from that. So the board approves this plan, and look forward to kind of hearing more updates about progress, particularly about the forest and the orchard. Right, thank you, everybody. Let's see if we can get at least the performance. We're still a little bit behind, but the Performance Committee AAA we might be able to cover, and let's see whether we can do Paper J as well, but we'll see how we get on. Over to you, Deb.
Thank you. I will take the report as read. The 3 advice items that I briefly want to cover was around the board assurance framework, where although we talked about the risks, but we specifically focused around assurance gaps in relation to that. And I know that that's something that Richard's team will be working on improving for in the coming months. And we also talked about the way that the group BAF will work in relation to our NHFT BAF and the interaction between the two. The reason why this is an advice is because it's a continuing ongoing work. And then the last 2 advice items are the financial performance in month 2 and the group value programme. In all honesty, that's been addressed by Paul already. In month 2, we were ahead of the curve because of non-recurrent savings, but clearly we have some quite challenging aspects around returning to pre-COVID levels with our bank staff, with certain services like the 0 to 11 and 11 to 19 children's services being really quite off budget, and the continued gap in the value programme, which brings me to the group value programme itself. And clearly we are very at the early stages of the financial year, and there is a number of areas where finalisation of the plans is required to ensure that we understand how and what level of savings we're able to make. Under Assure, the couple of things that I wanted to bring out, if I may, I will not spend much time on the integrated organisational report because that's the next item on the agenda. However, we did at committee reflect around the external environment, the movement of tectonic plates, as Krishna has alluded to, and the impact that may have on, or will have on, the IOR, which we look forward to seeing at Performance Committee first. We received the annual review of the joint ventures and collaboratives, which is always good to see. It's an annual report and it's very detailed, so the committee got a lot of assurance from that. The Green Plan refresh, which we've already dealt with, which we definitely welcomed, and we look forward to the regular updates. And finally, we received a deep dive on our waitlist management, fragile services, from Janisa Baines, the data validation team manager. As ever, it was a really detailed, very thoughtful presentation to really deep dive on the specific challenges that services are facing and how the team is supporting them. So again, Janice's presentations are always fantastic, and it just gives Performance Committee a deep level of assurance that wait lists are being managed. So I would leave it at that. Very happy to, however, answer any questions anybody may have. Thank you.
Thank you, Judith. Any questions for Judith or comments? Judith, I just wanted to say, I mean, I thought the deep dive on waitlist management was really helpful. I know it's alluded to in the integrated organisational report, which Anne will lead on in the next item. But I think the clarity about the data as well, the fact that it's 93% of all long waiters are actually related to 7 fragile services. I think that's really helpful context. And that kind of clarity is very useful. So good that the committee was assured. And I think given the conversation we had earlier about the importance of partnerships in the context of the estates, actually, I think positive assurance around our JVs and collaboratives. I mean, we do have a JV with one of our GP federations, don't we? So I assume that was covered within that. And I think, again, it's helpful that those there was a detailed update and annual review of that, because I think getting good assurance on those sorts of things are also helpful. So I just really wanted to commend the report and thank you for the work of the committee, which I think helps us as a board to focus on the things that we are getting assurance on, and where perhaps we are less so. So thank you. Moving on to paper 2. And it's the integrated organisational report. So over to you, Anne.
Thank you, Krishni. Okay, I'll take the paper as read, and I'll just pull out some of the key themes that that for me stood out in the report. So this has been an evolving picture, and I think it's great to see. It's never going to stop. It will always evolve, so that our performance reporting and oversight evolves with the changing times that we're in. It just noted that there's obviously a number of things ahead that we've talked about the tectonic plates. There's lots of things shifting that will inform this report as we go along. I think particularly for me, the neighbourhoods work will just change and morph just how we present and think about the work that we do and reflect the neighbourhood working, which I find quite exciting. I think also the greater drive around this constant balance between efficiency and productivity and clinical safety and finance, and how we manage that and how we reflect that in our reporting is going to be key as we move through this year. Obviously, changes with the NHS oversight framework, and you'll see some information on that in here, but that will also obviously change how this report sits. But generally, the report, as we have it as it stands, obviously we've talked waitlist earlier in the meeting. Our waitlist have risen by 579. That's always for me is looking at the increases and also looking at then how we're managing those waiting times. And as you say, and when we mentioned earlier, we've managed to hit the 18-week target again for the 7th consecutive month, which is good. So on that increasing picture, we're still managing. And also within that, the 7 services that we have had a much deeper understanding in the committees around the challenges and also the activity. And because we're able to identify it, you can see the tracked improvements. And particularly when I run through a few of the services, you'll see how out of those 7, they're not just sitting in a list, sitting still. There is constant movement on them. And that's through a lot of the productivity and efficiency work that Janice is leading on. We want to move to much more of a forecasting type approach and bringing that digital into the waitlist management processes. So that will also bear through in some of the future reporting, which is good. So I will ask colleagues to come in a second. There's obviously workforce and quality and finance that people might want to mention. I just wanted to mention the continued improvement in agency and how, as we were saying, it's challenging as we work through this year, but we're still seeing traction, and I think that's good. The bank work is very much in progress, and we've got a real sense of grip of how we're managing that, and it's then seeing the fruits of that work in the future. I'll leave complaints because we've got the complaints paper later, but just looking at some of the services, adults have been really focusing on some of the efficiency work, and we can see that in some of the outcomes for them and some of the things James talked about earlier. Just wanted to pick up for speech and language. Speech and language is a national challenge. There's not as many speech and language therapists in this world as we would like or need. But we are seeing a gradual improvement, and we're seeing recruitment, which is a really positive sign. From the ADHD point of view, as Dave was mentioning, really focusing on what those challenges are and listening to the national workforce group. But tech is something that we're constantly looking at, in particularly children's, and they're sort of embedding more there, which is showing small improvements, but with time. I just wanted to pull through on community peds. Obviously, we've had lots of discussion around that. I'm really glad you had a good visit. I think they felt the support of the organisation in the community paediatric team of us coming in and supporting and sitting with them, because it's hard when you know that you've got people waiting. From a national and regional picture, we're doing well. We're not where we want to be at all, but I just think it's often good to reflect and think wider than where we are, and that's important for the team to do as well, and take sort of some assurance that some of the things they're doing are making a difference. For mental health, a big focus on length of stay, and that's got to be central in the 10-year plan, and so that's key. I think also you can see in the mental health part, the talking therapies, there's a change to the measurements. And then we're sort of seeing when they change a measure, you need to change your workforce to meet that. So we're seeing that kind of process rolling through, but they are next on the productivity and efficiency, looking at how with the changes to the measurements, access has been a drive of just get as many people through, and actually we need to be a bit more productive about what happens at that front door. So that's a really good and exciting for the teams. So I think I'll leave it there on my aspects. I don't know if any of my colleagues want to come in on any of the other chapters of the report, but I hope that gives a kind of an oversight.
Thank you, Anne. And I think there are a couple of colleagues who want to come in. So first of all, Paul, please, and then Itai.
Yeah, thank you, Krishna. Just to draw people's attention to where we are at the end of month 3 for finance. And again, this sort of has been a feature through our conversations this morning, but also will be a huge part of the oversight framework that has been refreshed nationally. So when we see more on that, finance and remaining on plan is a critical part of that. So we are on plan as far as month 3 is concerned. That has taken some non-recurrent aspects to be able to keep us on plan. But as I mentioned earlier, around where we are with our value programme, we keep progressing towards the full amount. That still remains our biggest financial challenge going forward. There are some things that we need to keep working on. Anne's already referenced the bank work and the reductions there that we had in our plan that was signed off at the beginning of April. And so those reductions we've not seen through Q1. In fact, we've seen more of a use of a bank than we had planned. So we've got more reductions to come as far as that's concerned. However, we are very close to being at 0 agency for non-medical agency across the trust, which is a huge piece of work over the last 18 months and nearly 2 years. Yeah, I'll probably leave it there, Krishna, as far as the finance section is concerned.
Thanks, Paul. Itai, please.
So I was just going to say, just in terms of the performance in in community peds, whilst we were sat speaking to them regarding some of the challenges with the waiting list, particularly around neurodiversity, we got to hear from them about how they are thinking about some really creative solutions for for powering through some of those assessments and working together. And I think a co-production with CAMHS is certainly something that they've spoken about, and something that we will encourage them to do. Just looking at the workforce, seeing how they can bring in sort of non medical prescribers into the fold to actually support with some of that waitlist management. So I think it's really good to hear them coming up with some of the solutions that they've got for how they can manage the problems.
Thank you, Itai. So any other comments from or questions from colleagues regarding the report? As always, it's a very comprehensive report and very easy to follow and read. So I do enjoy reading it. And I think, Anne, you made a really important point earlier about the balance versus, the balance of, this is the real challenge through the course of this year, isn't it? Getting the balance right between keeping our patients and our community safe and delivering on our financial asks. And so making sure we keep focused on that, I think, as a board, that we're assured that we're getting that balance right is really important. I just wanted to reference very briefly, and just out of interest, you mentioned the speech and language therapy professionals, and actually, as it happens, the LPT Public Board had a patient story and staff story from their SALT team, and what it struck, I think, what was really striking was what a significant role those therapists can make with the broader well-being and prevention and early intervention aspects. So we heard a lot about how the team had worked with patients to help staff manage personal care better in care homes and things like that. It was really powerful, actually. It really made me appreciate how much of a difference having the multidisciplinary team set of skills can make to that broader piece around keeping people well at home, or keeping people well in their in whatever setting. I mean, they particularly talked about care homes as well, mainly because obviously we were talking about potentially frail elderly people who had challenges with language speaking, inability to communicate, really. So it was incredibly powerful. It really, really struck me. But also it made me think, I wonder whether there's enough speech and language therapists coming through, and are we attracting people to that kind of role, because it felt like a really important opportunity. You can see a couple of other people want to come in. So actually, Richard Amponza.
Thank you, Krishni. Yes, a lot of the detail in the IOR is already included in the Patient Safety and Learning Assurance Report, which I'll be sharing with colleagues. But I just wanted to highlight that our weekly triangulation report and meetings, continue to highlight areas where teams have had more than their fair share, if you like, of incidents. So it just gives us the opportunity to focus in a bit more and just to explore to find out what is happening. We also have weekly meetings with our safeguarding colleagues just to share some insights. And we're also taking a very close look at low and no harm incidents. As colleagues may be aware, we do review on a regular basis all incidents of moderate harm and above that are reported through our data system. But we are now reviewing also the low and no harm incidents, because sometimes incidents do kind of, fall through the cracks. So this gives us an opportunity to mop up all incidents so that nothing is kind of falling through the cracks. We also have weekly meetings. Our patient safety manager, our nominated rep, will attend our care delivery pathway meetings just to share ahead of our weekly ROSE meetings any concerns, any of the cases that have come forward before they actually come to ROSE. So we kind of are on the same page in terms of what we're looking at and what the ROSE outcomes will be. So just wanted to share that with colleagues.
Thank you, Richard. Really helpful additional assurance. Anne, please.
Yeah, I'm just going to echo some of the around speech and language therapy. It always brings such a refreshing, broader picture and perspective to a team. Just from two factors, I think it's going to be really important around the sharing in group work around children's to see how we can share and innovate together. And also, I know that both teams have looked at different ways of doing very innovative sort of career progression and looking at pipelines and making the absolute most out of bringing people into the organisation. So I think the group focus on children's as a whole will really help us to hang on and develop some of that.
Yeah, thank you, Anne. Melanie?
Yeah, there are probably many people on this call who can talk about this far better than I can, but I just wanted to reference as well in terms of waiting well and supporting people. The iDiscover, the mobilisation of iDiscover and sort of moving across into giving people online resources to support them, a sort of online version of our recovery college, if you like. And within Community P's, there was a very clear focus, recognising how children often are more accepting and more have digital media is more accessible. Having online resources that provide support both for individuals and for carers and family can be a really important way, not only to sustain people who are waiting a more specialist treatment, but also in many cases actually provide the resources that they need that reduces and in some way, on some occasions even removes the need for them to see the more specialist resource. So a really great initiative that I think it would be wonderful to showcase at some point in the future when appropriate.
Great, thank you, Melanie. Dave, please, final comment.
Thanks, Krishna. Just to update, Julia and I had a good session with the Complaints Committee this week. I'm promising developments in Equivia. Richard was also there, of course, to see kind of improvements in patient-reported experience measure. So we will be ramping up our ability to collect the information in that space. So that's really positive. That's been a long time in development, and it feels like it's gaining good traction now, which is critical for particularly our friends and family test. And just to reflect on the people dimension of this, Dion's obviously in her interim role currently. There would be further work with People Committee, with Tim and Dion in that space to help us finesse a more programmatic approach to some of the people work that is ahead of us. Because as I've updated on Mars, there is a challenging context that we're working in, so that will need to be reflected in these reports as we get into some of that detail.
Great.
Thanks, Anne, for covering.
Thank you very much, Dave, and thank you, Anne, and other colleagues for their input. So we're asked to note that report, which, as I say, I think is very comprehensive and really outlines all the areas of performance that need to be highlighted to the board. And we obviously, and I'm sure, would want to say, that despite the challenges, we should thank all our colleagues who keep our services working and contributing to delivering care to our patients and our community, which is so important to us. Thank you. We'll move on then to the quality section of our agenda. So we'll start with Julia on the highlight report from the Quality and Safety Committee. Please, Julia.
Thanks, Krishni. Excuse me. So I'll take the report as read. Just wanted to mention that we did defer 3 papers this time, just because we didn't quite have the appropriate representation to be able to deal with them, and we will be taking those into the August meeting. So that they will be scrutinised then. Just from the advised section, you'll note that in the second box, we talk about an issue which is an area of clinical practice which is normally undertaken by primary care, which is complex wound management and wound care. And a number of GPs actually stopped this practice as part of their collective action, and that hasn't resumed. It's had a bit of an impact because there was a presumption that our tissue viability nursing services would actually take those patients on, and we're not commissioned for that across the county. It's having an impact on people, obviously, and so it is a risk, and the ICB are well aware and are actively working with us, I believe, behind the scenes to try and get a resolution to that. But just to say, it was raised at both the Safety Committee last week that I attended and actually the Complaints Committee yesterday, because it is an emerging issue. So just to keep the board aware. Just in the assurance section, going back to patient feedback that we heard about from James's patient story, we had an assurance session around the IQVIA platform that we use to gain feedback. And we'd reported through to the board previously several challenges through various aspects of the system, and we were presented with a recovery plan, and we were assured by the continued work and progress to that, and it was a really good detailed session, so we felt quite assured with what's going on. And again, yesterday at the Complaints Committee, we heard a couple of updates that the ongoing issue with being able to use SMS messaging, particularly for children and young people, is about to be resolved, which was wonderful news, because that's expected to increase our feedback, particularly from that group of people, very significantly. And we also heard of a new tool that secured services are developing in the IQVIA system to be able to get tailored feedback from people within our secured estate, within our prisons. So particularly vulnerable group of people. So great to be able to receive feedback from them. A couple of routine things. We approved the quality account on behalf of the board prior to its publication in June. And then we mentioned again this morning about feedback in the patient story. We had both the Q4 Complaints PALS involvement and feedback report and the annual report, which is Appendix 1. And I think the reduction noted in the annual report of complaints this year, huge focus over the last few months on local resolution, so that services and staff actually work with patients and service users to actually be heard, so they're heard, so that people don't feel they have to escalate to a formal complaints process. So that's really good. From a safety point of view, we had 3 annual reports, so apologies, these are appended, multiple appendices this time, but they're important that they come to the board. the annual fire safety report, the annual safety report, and the end of year security report. So obviously at the end, if anybody's got any questions, that's fine. We did a short deep dive on RIDDOR incidents, reporting of injuries, diseases, dangerous occurrences. And that's important because this is about incidents that happen to our staff who may then result in taking time off work. And we were assured by not just the process that we have in place to report them, but actually the actions taken and the themes that came out. You'll notice the last attachment I've added, attachment Appendix 5, is a summary of the committee workshop we had a few weeks ago. And there were two really key areas of practice we looked at: management of medicines across our services and keeping people safe, which is all related to the work of our risk management project group around staying safe from suicide, recent guidance that came out. But if you look at the appendix, the fundamental thing that I wanted to pull out from that was that we've, as an organisation for the last year, taken a completely changed approach to risk assessment for people with mental health challenges. And we've moved from a risk stratification process of whether we think we predict people are high, medium or low risk of concerns towards a more holistic, compassionate and person-centred approach. So that's really important, and I just wanted people to just make sure that they'd seen that. We looked at our two new BAF risks, but they weren't complete. So we've now approved those this morning, but we will be looking at those in detail later in the year. And I absolutely wanted to celebrate outstanding at the end. Michaela Cox, our chief pharmacist, leaves NHFT today, I think. And we just wanted to thank her at the time for she's been a passionate advocate for medicines governance and a key component for Quality and Safety Committee assurance. So we wanted to say thank you to her. So I think that's probably a whistle-stop tour of a very busy committee. Just wondered if anybody had any questions or comments.
Thank you, Julia. Any questions then for Julia, or comments or observations on the report, or indeed on the number of key reports that were appended for the board to have sight of? I think helpful that Quality and Safety review these in detail for us, but also that the board is cited on them and able to ask any questions, which is a helpful practice, I think. Julia, I was just going to mention that so it's really good to hear about the staying safe from suicide. Now, interestingly, Robin and I, Robin will know what I'm going to say, were in conversation with some of our governors, and at the recent session, in fact, with KGH governors, I think it was. And it's just a little bit of feedback. I mean, I think it was quite clear that there had been a very comprehensive session in the Quality and Safety workshop. I think the feedback from one of our governors just raised a little bit of a question about, have we done enough communication on the new approach? And does everybody, I know that Robin will know better than I because he was there, but I know there was a sort of comprehensive view on the training and everything else, but it just felt like, and maybe Robin would like to come in on this, there might be a need to just make sure we have absolutely communicated this new approach to everybody. I think that was, Robin, do you want to add to that?
Yeah, I mean, the point was made by a staff governor rather than an external governor, so it was a useful contribution. I think the point is we are still at quite an early stage in the implementation of this new work, and as Julia has outlined, we had a really comprehensive and detailed presentation about what is being done to implement this national guidance, because that's essentially what's happening. There's overall guidance for the NHS as a whole, and we are implementing this at pace. And indeed, we're ahead of quite a lot of other trusts in terms of the level of implementation we've done. But it is still early days, and communication to staff will take time. And but it was a useful question, really, to remind us that even though we see stuff coming down the line, it does take a while for it to penetrate down to all staff levels. So it was a useful reminder that we do need to continually review our communication programs for new initiatives.
Thank you, Robin. Really helpful context to my comment there. So, yeah, so it was only really not for nearly necessarily a response, but just really to make sure that we have that kind of consideration of how strong and deep our communication is around this initiative. I think the implementation date, the final implementation, is March next year, if I remember correctly from something I read. Is that right, Julia? Do you know of the top of your head?
I'm sure. Anne, I don't know whether Anne might be able to. I mean, we've been working on this for over a year, is what we've been hearing, but actually then the guidance came out specifically. So I think from that guidance, I think possibly you're right, it is next March, and Anne's nodding, I think.
Yeah.
But actually we'd be doing a lot of work well before that.
Already, yeah. So just something about noting that we need to continue the efforts to make sure everyone has received the communications about this new approach, and continue to work on that. But very comprehensive report. So thank you, Julia. Anne?
I was just going to say on that, although they've set some stage times throughout the years, because it's such a cultural change that this will always be continually developing and tweaking, and the training for staff, in case anyone sees it, is going out as soon, which is really been quite innovatively done. So it's an ever-growing programme.
I wonder whether there is some value. I'll sort of open this up to kind of nods or thumbs up or thumbs down, but I just wonder whether it might be helpful to have a joint in our joint development session, Richard, because we've got one coming up, a sort of a briefing, a taster for board members to understand the change, because this feels really important. I'm sure executive colleagues will be more familiar with it, and I know Julia and the quality committee have already had sight of what's happening, but perhaps just a short session just to understand the kind of way it's changing, how it links with the learning we've had around the Section 48 review, for example. I'm just wondering whether colleagues would find that helpful. Julia?
I think that's a really good idea, Krishni, because one of the areas we looked at and questioned was actually, could this approach be, used across many other services, that not just specifically mental health services? And I know, and we were looking at that. So again, it's something that will actually affect the entire. I think it's an approach we could have for all of our patients and service users. So I think for everybody to be up to speed would be really useful.
Okay, so that might be just something we think about, Richard. It may not be the first on the list, but it just might be useful to make sure board colleagues from both organisations are cited on the changes and what that might mean going forward. So thank you very much, Julia. We move on then to the Patient Safety and Learning Assurance Report. And I'm handing over to Richard at this point. Richard, just any highlights that you want to bring to our attention would be great. Thank you.
Okay. Thank you, Krishni. So taking the report as read, the top 5 safety issues for us as a trust are pressure ulcers, self-harm, medication incidents, falls, and then violence and aggression. All these incidents, as I've said, are reported via the Trust Data Incident Reporting System, and they receive a due review and exploration at all the various meetings, ROSE being one of the key ones. And as I said, includes low and no harm incidents, not just incidents of moderate harm and above. So just sharing a bit of the stats with you in terms of the pressure ulcers, just going through that. Before I go to that, of the total number of incidents, we had over 1,700 patient safety incidents reported as attributable to our organization. Of course, some of them are not always attributable to us, so it's important to make that distinction. So this equates to an average of 885 incidents per month during March and April of this year, and that compares to 1,698 patient safety incidents reported in March and April. The top 5 incidents occur within adult mental health inpatients. That's where we have quite a number of incidents. We have CAMHS inpatients as well. There are incidents within community nursing and then ICT. So consistently, they report their highest number of incidents compared to the rest of the services we have, and they account for over 51% of the total number of incidents reported for May and June, and that is a 3.96% increase over the previous reporting period. A way of pressure ulcers, colleagues would know that since I think April 2024, we have instituted a director-led process for reviewing all the pressure ulcers within the trust, especially those of a grade 3 and above. We're particularly interested in pressure ulcers that are inherited when patients come into our care. So we make a decision between that and pressure ulcers on admission. And the table within the report shows that since we instituted this practice, it's given us a firmer grip and oversight of the management of pressure ulcers, and we are able to report a lot more promptly on it and put in place any mitigation that is needed to make sure that pressure ulcers are well managed. This meeting is attended by our tissue viability nurse, and colleagues come to the meeting prepared to share pressure ulcer information and also to share what they've done to try and manage the pressure ulcers, and even when we've inherited them, to stop any further deterioration. And of course, our absolute priority is to make sure that people don't develop pressure ulcers whilst they are under our care. There's also medication incidents, and of that, 5 incidents were reported as moderate harm and above that required hospital intervention. 1 incident was reported through ROSE, and there was no further action following the ROSE discussion. 2 cases reported as moderate harm remain under local review, and were yet to be escalated to ROSE for further discussion. The 2 final incidents were reported as severe harm, were both reviewed and presented to ROSE by the task force lead, and no further action was required from those reports. I've already touched on violence and aggression. During May and June 2025, 2.88% of all patient incidents reported were categorized as violent and aggressive incidents. 51 incidents were reported on Datex within the 2 months, compared with an average of 3.27 violent and aggressive incidents each in the month in the preceding 12-month period. Of the 51 incidents, 82.35 occurred within inpatient mental health settings. And as I said, that is where we have the majority of our violence and aggression incidents. The incidents are also discussed at the patient safety meetings, which are chaired by our COO, and Ian shares heat maps that help us to focus on the areas where we have the most incidents and just help us to also develop a mitigation to support that. Chris Beck, who's our restricted practice lead, is doing some innovative work in terms of helping to understand and also to support staff that are unfortunately the victims of these violent and aggressive incidents, and actually reporting sometimes to police, not just to be punitive, but helps us to be able to build a profile of patients' risk, so that when they come into services, we know how best to support them and work with them. So yeah, I'll leave it there and invite comments and reflections from colleagues.
Thank you, Richard. Any comments or questions for Richard? Julia?
Thanks, Christy. Just say, so I go to the safety group, which was actually last week, and the ICB quality lead for care out of hospital attended, and I think she's going to attend regularly, which is a really helpful addition to that group, because I think then the ICB get a flavour of what's happening and can contribute. Just to say that huge improved position around unassigned investigations. I don't underestimate the work that's taken to get to that point. A year ago, we were not in a good position, and we alerted the board to that. And actually, to note that improved position is incredible, because it's a huge amount of work by teams, services, and your teams, Richard, to get to that point. And I just wanted to pull out the learning from deaths, because it's really the report and the assurance really important for us to understand as a board. We've had no deaths that have been deemed as potentially avoidable. That's really important, and there's some great learning coming out through that report, so just urge people to just have a further read of that report. Thanks, Christian.
Thank you, Julia. And no, I think we definitely saw the movement in terms of outstanding reviews. That number had reduced significantly. The only thing that did catch my eye, and it is relating to an outstanding or would appear to be relating to an outstanding review. And Richard, you may not be able to answer this, but there is a thematic review referenced under the section thematic reviews,
Yeah.
and it's number one, poor escalation of news has been identified as an issue across the trust. It says that a report will be submitted for review by the end of Q4 2024. That worried me somewhat in terms of the date. I don't know whether that's a mistake, whether that should be Q4.
Yeah,
I wasn't absolutely clear whether it was saying it's 2024-25 or 23-2024, but obviously if it's very old, then that would concern me, because escalation of news is an important area of focus. So Richard, it may be that that's an incorrect date, but I just wanted if we could check.
It's not incorrect, but I can report to this forum that report has been completed and submitted and is being reviewed. So we don't have any outstanding thematic reviews. That news one has been completed. Yes, it took an awfully long time for a number of reasons, obtaining the right data, getting to interview people and all that, but it's all been signed off. So yes, I have reported to, I think, Tom G. On the last Tom G, we reported that the report has been handed in, so we don't have any outstanding thematic reviews. So that's the latest on that. And just to comment quickly on Julia's point about unallocated investigations, yes, we just want to commend the team, the clinical investigations team, for the hard work they've done in making sure that we don't have those, because we had them on our risk register at a point. That was how concerned we were. And of course, it doesn't do well for our relations with our patients and their families when incidents take that long to investigate and to draw out learning. So yeah, that's a very good place to be. So quite pleased to report that.
Thank you, Richard. So I think if there are no further questions, and we've had assurance about that thematic review being completed, and we can note the position and the assurance provided. I do find the SPC charts in this report very helpful as a sort of way of providing a good, very easy way of seeing what's happening within each of the areas of major incidents, really, themes. So thank you. We then move on to paper M, which is the Workforce Safeguards report. So back to you on this one, Richard.
Thank you, Krishni. So yes, taking the paper as read, just to highlight, it's shared in the AAA format, so highlight the alert, advice, and assurance. So the alert continues to be that we are carrying a number of registered nurse vacancies, support staff, healthcare assistants, and allied health professions come under that bracket as well. Vacancy rates have gone up for staff groups, apart from support staff in medical and dental, which have decreased slightly. But there's a table in there for vacancy rates for June 25 that clearly shows, where the gaps are. But I do know that there are efforts in place to try and fill these gaps. But it is something that concerns us in terms of the number that we have, and especially I think within specialists in secured services, we have quite a number of RGN vacancies that we need to fill. So that's ongoing, but I think there are programs in place to fill this. I think it's been reported at WEP that there are programs in place. So hopefully we will see a turn for the better in that. So those are the alerts. There are a number of charts in there that help to break down and make it clearer, kind of tell the story a bit better. By way of advice, 34 members of staff commenced work during May 25. 4 transferred from bank to substantive, which is testament to the work that we're doing to try and encourage our colleagues to join us in a more kind of substantive capacity, because we were concerned at some point that people were just thinking just because it's bank and not agency that is okay to kind of keep booking. So being able to work with people to get them to join us in a substantive capacity helps, because then it means we can support them even better. Another item of advice is the contingent staff controls, including banking agency spend, are reviewed as part of the CDPM meetings. Staff bank recruit on a rolling basis once a month, and ad hoc recruitment is available to managers as required, but that's for specialist areas. So we're not just going and willy-nilly booking bank. So that's a good position to be in. Starbank are heavily involved with the web in terms of making sure that they provide us with the updates that are required to keep us informed on the work we're doing to make sure that we keep our vacancies at the right level. There's a table there which shows the bed occupancy rate, which is a key part of this report, which for all bed occupancy rates that are below 90 are reported for June. So it goes through all the wards from Brookview to Corby Community Hospitals. There is also an item of assurance or items of assurance that I'd like colleagues to note. Staffing duties are populated 6 weeks in advance. One of the points that have been shared was the fact that people were feeling like, rotas weren't published well in advance for people to be able to plan their lives and book leave. So that is now very firmly in place, and it's something that we look at as part of the data that is shared at our weekly web meeting. So rotas are populated 6 weeks in advance on eRoster to ensure there's enough room, enough time for people to plan and to so that we don't have last-minute requests for leave. Ward matrons conduct daily reviews of actual staffing and deploy staff to needed areas as indicated. We continue to record safer staffing and use care hours per patient day metric via the monthly unified report, which is signed off by Linda. Safe staffing continue to confirm and challenge all fill rate figures, paying attention to any variance below 90% and above 120.
Okay.
I think
that's,
is
unless there's anything else, Richard, I think that's probably the key points, isn't it, in the report? So are there any questions that anyone would like to ask regarding or comments? Duncan, please.
Yeah, thank you for your report, Richard. The questions I had were essentially two. You describe in the report the establishment reviews. I wonder whether you could give us any comment as to whether the budgets of the establishments have been moving around much year to year following that, and whether that's distorting in any way what we're seeing in terms of the vacancy rate. And then second, I wonder whether you could give any comment on the length of time that individual posts have been staying vacant, how you keep a monitor on that. I have in my mind, as I ask this question, Richard, the danger that happens if a post is left vacant for a very long time. It might be because methods of work have changed and it's no longer needed, or it might also be that we have a risk there that we've not really brought to the front of our minds. Thank you.
Richard, I'm not sure you'd be able to answer about all services, would you? And how long they might have vacancies. So I'm just wondering whether Dion and Anne would want to help with that. Dion?
Yeah.
Or Anne, whoever would like to go first.
And you go, but again, I was just going to talk about the controls we have around.
So I think it's fair to say this is a part of the picture. So within each of the operational services and the pathway. So James, as we had his example of the adult pathway, will go through reporting to on vacancy rate. But he's gone through a process with his teams, as have the others, on understanding every single vacancy, how long they've been, whether that's, as you say, is that to do with what's required in this changing world, what the risks around it, and how do we manage that process, because it's been a key part to how we manage agency bank, and so it's part of that deep dive process, and it is done post by post or vacancy by vacancy, as well as thinking about what is needed from a risk point of view to manage the services effectively and make sure people get good care. So that is an iterative process that goes on, I mean, constantly, but through WEP on a weekly basis, through the workforce meetings on a monthly basis, and reported up to my operational management group from my point of view to understand what's happening in each service. So there's quite a process around it. And I think part of that will have to shape what decisions we make moving forward on how services look and how effective we can be in this challenging environment. So it's quite a big piece that we work on around those workforce safeguards.
Anne, and just for members of the public, can we just remind people what WEP is? We've referenced it a few times.
Yes. Sorry. Workforce Efficiency Panel, which is our sort of a process that was put in at the beginning of these challenging times, and has very much that grip and control and oversight, really understanding where we've got vacancy, where we might use agency, how do we make the best of the resources we've got. So that is a weekly process where we review every single sort of emerging establishment issue.
And Tim, I think workforce, this report actually goes to People Committee as well, doesn't it? So it does get some additional scrutiny there, Duncan, for ensuring that we're reviewing kind of long-standing vacancies, etc. So Tim may wish to come in at some point, or we can link to the People Committee report. But just
it's covered in the AAA, Krishni.
Yeah, thank you. Dion?
Yeah, I think again, Anne's covered the position in terms of the controls, Duncan. So hopefully that gives you a sense of how we manage that. I think what I would want to highlight as well, I think, is we also use that as a good opportunity to share learning across different areas. So in coming together collectively, we are creating those regular spaces. We're obviously doing deep dives and focusing on particular areas, but we're making sure we widen the breadth and look at how we can share learning across areas and how we can actually incorporate other feedback, other good initiatives that we're seeing across potentially other trusts. So I think it's building into the WEP now that we've explained it, but all of the process around that build into quite a robust way of managing these challenges and supporting our colleagues across the trust.
Thank you. Robin, please.
I mean, this is an important report in terms of a number of different areas because it covers quality aspects as well. I was just going to draw attention to the bed occupancy discussion because there's so much in there about so many things, and it loops right back to Barry at the start. We saw the 100% take up of all those kind of beds that he was occupying, and the need to find ways of reducing that demand is enormous. And we are achieving that reduction in demand in other settings. So the sets and the boroughs who they're under occupied because so much good work is being done in the community. So there's an enormous amount of really useful information in that very short discussion, not least of all, back to the community adult beds, the pressure upon the matrons and the senior managers in terms of being required not to do management, but to do clinical work covering the rotas. So there's all kinds of pressures in there that are highlighted, as well as some very positive things about reduction in demand. So there's a lot in this report for many areas.
Yeah, thank you, Robin. Richard, back to you.
Thank you, Krishna. Just a quick comment on Duncan's question about how some vacancies might remain on the books for a long time. Some professional groups are really hard to recruit into. So SALT and speech and language therapy, for example, SALT is notoriously hard to recruit to, as are podiatrists. So sometimes they will remain on there for a long time. But something that the managers do is something they do sometimes some skill mix just to blend things, just to make sure that where they are really hard to recruit to and they are not able to recruit, they blend and mix with other professions to see if they can provide some mitigation whilst they're still hoping to go out to recruit. So yeah, some professions are just hard to recruit to.
Thank you very much, Richard. And I was just really going to highlight, I think there was a reference to, and I'm possibly Tim will pick this up anyway, but I think there was a sort of start well, work well, and there was something, there's the program of work. I really just wanted to emphasize the start well, because I can tell you that from a regional point of view, I have seen so much data that suggests that, I'm not saying specifically to NHFT, but that many people start in the NHS and leave within the first year, too many people. And actually, particularly healthcare support workers or in that area. And that was really a feature. At one period, we were driving regionally and nationally to recruit people, but it was literally 50% were leaving within the first year. And so there was just something that start well. As you know, we've got to recognise, and I know we do because we've talked about it before, the importance of doing that initial process really well, because if we keep people, retain people in that first year, they probably will go on to stay for a much longer period of time. And so the support and the ongoing kind of the onboarding process, and even the expectation, actually, the management, particularly for people who are unfamiliar with the NHS, I think. There was a lot of feedback suggesting people who were not, who were coming in from healthcare support worker type roles, they found the environment much more difficult than they expected it to be. So I'm sure we're all over those sorts of issues, but it was striking to me how we used to, how collectively as an NHS, how many people we lose in the first year. And that data, do we monitor that data, by the way? At all? Beyond?
Yeah, we have dashboards that do look at that information and data, and again, it's squarely part of the Stay Well group, so looking at initiatives that we can do to address particular areas.
Great, good. So very comprehensive. Thank you very much, and we thank you, Richard, for stepping in to cover for Linda today, and for your input in relation to that. And we note all the updates that have been provided and the importance of this report, because actually, as Robin says, it is, whilst it's a people report, it is actually the reason why it has historically been in the quality section is actually because it links you know, the whole experience of quality and delivering quality with the sort of sufficient workforce levels. But thank you. We move on then, Tim, to you for paper N, which is the People Committee report.
Yes, so paper N, triple A report for the People Committee on the 5th of June. I'll take the paper as read. There were no items under alert, and there were 4 under advised. I'm just going to pull out specific elements of. On the workforce dashboard, the reason it's there is actually that medical staff appraisals were low, but ITI's team have done some really good work and have identified a delta between the report here and his reported data as well. So that work is in hand and is tracking in the right direction, but we just want to get it married up. So the data needs to give us credibility in the report. So that's why it's in there as well. Monitoring workforce safeguards, the paper we've just had. The alerts for registered nurses was also recognised in the committee as well. So that was well signposted by Richard just a moment ago. And to reference the Start Well, Stay Well, Leave Well, as we call it, the Employee Life Cycle Initiative, that is flagged. It is in there as well, Krishni. So everything seems to dovetail there. And then the last one on the risk report on the BAF, there was just a debate and discussion about the lack of certainty for an awful lot of people around system plans, both in NHFT and the wider NHS system as well, just recognising that risk across the system. And then under Assure, there were 3 annual reports, the WRES, so Workforce Race Equality Standard, the WDES, Workforce Disability Equality Standard, and the Annual Organisation Audit, which are appendices 1, 2 and 3 attached. There was a discussion about the freedom to speak up, and the annual report is the next agenda item. We celebrated the agency spend report because I think Paul referenced this. That's been 18 months of very hard work to get to a position where certainly in my tenure, it's the first time we started a month 1 beginning of the year to be down. So it puts us in a really good position and not to be chasing our tail. We'll skip over bank briefly now because that isn't in this particular report. And then just to flag that the People Committee workshop was delayed due to attendance, and we've rescheduled that for August as well. Any questions?
Thank you, Tim. Lots of really good content in there, and not least the it's time for annual reports, isn't it? It's just that time of year, so there are a number of annual reports in there. So any comments or questions? Obviously we picked up a little bit around people on workforce safeguards, but anything else that people want to comment on? Just really thank you for achieving our agency targets so far this year. I think that's a really good start. We were, before COVID, we were one of the organisations who was under our agency threshold, I think, as it was known. So it would be very nice to go back to that position for the year, because it was one of the things that I remember celebrating alongside our outstanding rating in 2019. So yeah, well done, colleagues, because that is really important. And I really just wanted to mention the RES model employer data, because, you know, to really be ahead of our model employer aspirations is really positive. I'm not sure I'd have anticipated that when we started that journey some years ago. And whilst there's still a huge amount of work to do on RES, I think to be able to say we're ahead of those aspirations, that our workforce is more representative than we would have anticipated when we started, I think it's a really good place to be, but a lot more work to do, so we recognise that. So thank you, everybody. We note the report, which is really helpful. Welcome, Luke. Good to see you. I'm sorry we're running a little bit late, hence you've joined, and we weren't quite ready for you. But I think delighted as ever to have the Freedom to Speak Up annual report. And I think, Dave, you're going to introduce this, aren't you?
Yes, Christian, I'll give broader headlines, and then we can just open up for any comments. I'll ask Luke to make some short comments and then questions. So just, we've got, as you say, annual report season. This represents the Freedom to Speak Up report. We continue to run the accountability structure in place with Ned, Chief Exec, oversight, meeting regularly with the Guardians. Now that we've got Luke and Beth working in a job share, and I have responsibility for line management support for the team. We're doing really well on training, consistently kind of one of the best, the highest rated training across the trust, which is again really positive, and increasingly that will become more important as we move into other services across the region and nationally. Number of issues have increased by about 2, I think, in this year, so 163 against 161 last year. And as we updated previously, with secured services coming on board with a 10% increase in staffing within the trust, we would expect that to probably increase, and indeed it would be a measure of concern if it did not increase over the coming year. We continue to have good, really positively, numbers of people who are raising concerns confidentially and openly. You know, is vastly greater than the number of concerns that are raised anonymously. We've just had 7 in the reporting period, and that's really important because it gives us some confidence that even though we get feedback that people feel uncertain about how their concerns are concluded, people continue to persevere with raising those concerns in a confidential and open manner, and that's really, really welcomed. And of course, people who raise them anonymously is also welcomed, but a good measure that we're heading in the right direction in terms of addressing concerns. Key themes, as are in previous years: employee relations, recruitment equity, which we've got some strong programs in place, patient safety, which we described earlier, and inconsistent support during HR processes. So we have got plans around all of those, and indeed recruitment improvement plans rather, in place to address those in this year and into 26-27, particularly in relation to feelings around recruitment equity. We are developing a risk framework for the concerns that come through, which will give us greater clarity on the patient safety elements so that we're able to quickly respond to those. And we're also doing a piece of triangulation work across concerns raised through grievances and indeed concerns raised through complaints, plus other metrics that we're using across the trust to have a more coordinated, data analytically driven review of issues that pop up across the trust and whether they are triangulated and indeed whether there are any systemic issues that we need to address. And that brings real depth and richness to our ability to get to the nub of the issues and respond to them in a really, really quick way, which is our ambition. It's a typo in relation to some of the activity during the Speaking Up month in October, but we continue to recognise that as a trust, and we're looking to expand our champions to include more medical colleagues from the medical disciplines within the trust, which again gives us a wider breadth of experience and perspectives across the trust in supporting colleagues who want to speak up. So I'll pause there, Krishni, and Luke, if I could just invite you to give any perspectives from yourself as Guardian and obviously representing Beth in that sense.
Yeah, thank you. I think the anonymous numbers are really important to hone in on. We're only hearing 4% for the last year, and when you compare that to nationally, you would expect to see 9.5%, but that's additionally with the added context that a lot of organisations don't even have an anonymous reporting route, which we do via the staff room. So it really is encouraging to see that staff are comfortable to come forward, even if that is only just sharing their details with us. Obviously, Beth and I continue to support staff to raise concerns directly where they feel comfortable to, and even in situations where they ask us to sort of make that first contact, increasingly staff are happy to put their name to their concerns and address that with their either their line managers or their senior leaders. And obviously not for this report, but Q1 we're seeing a continued increase in people raising that openly. So that seems to be a really positive trend. Just highlight, we are planning and considering the completion of the reflection and planning tool jointly with LPT. We are now looking at doing that in November, which is slightly different to reported. And again, we're aware of the new secured services coming on board, and we're looking at doing a bit of targeted work in raising awareness on all of our new colleagues that will be coming over, highlighting the different avenues of support that they can access, including ourselves as Guardians. And again, yeah, I would expect to see an increase in concerns from those areas. Just those periods of change are always gonna flag things up. And I suppose generally, again, we're going to look at applying the risk matrix against concerns, as Dave mentioned. We have seen a reduction in patient safety concerns as compared to previous years. Staff do report when we question their confidence in speaking up that they are generally quite happy to address those via the alternate routes. So, for example, the Datix incident reporting. And hopefully we're hoping that the risk matrix application to the ones that we do get will allow us to report a lot more robustly, give a lot more information in terms of the severity of what's being raised to us. And again, feedback has been widely positive, highlighting the appreciation for the role and the safe space that people have to raise their concerns. We have had some comments around the wider organisation ability to act on the issues that are brought forward, with outcomes not always being followed through. Again, that's a small percentage of the feedback we're getting, but I think that is important to highlight those voices that are feeding that back. Thank you.
Thank you very much, Luke. So any questions or comments from colleagues? You did, please.
Thanks, Krishni. Welcome, Luke. Great to see you. Just a really quick question, and I don't know whether you, Luke, or Dave can sort of just address the question that we've raised a number of times at this board meeting, which is the national picture. I mean, clearly there are going to be some changes with the NGO. Is there anything that you are able to share with us right now, and any potential impact, or is it too early?
So the information, obviously we attend our regional networks, and we've had some updates from the NGO there. And the information that we've had is it is very early days. We haven't got a complete picture what that looks like. The understanding is that the functions of the National Guardian's Office, the NGO, will be pulled in with NHSE in the short term, with a longer term plan of that being absorbed into the Department of Health and Social Care. We don't have a picture in terms of what functions are going to remain and what functions are not. In the meantime, we're still reporting our national figures into the National Guardian's Office. I presume that will continue to be reported into the same system for NHSE in that short term. But that's all the information that we've had provided to us as Guardians.
Thank you, Luke. Thanks for the update.
Thank you. I think it's really important to go back to what Dave said. That doesn't need to change anything we do or the commitment we have to Grid and Speak Up and the approach we take. I think it is, you know, that there will be a question for NHSE about how national reports are pulled together and how data is extracted and all of that. But I think a lot of, if I understand it, and you did, probably you will have had experience of it. I think some of the support, well, Luke will undoubtedly be getting, there are some regional networks already, aren't there, Luke, that you've referenced. But I think the important thing is the support, kind of maintaining support networks and networks that help us work together. And I think the region quite successfully, Melanie, has done, and Tim has probably experienced this now, does support wellbeing guardians, for example, very well, don't they, from a NED point of view. So it has some experience of that. So I would anticipate that although it sounds worrying, I'm kind of less concerned about it, because I think the principles are not going to change. It is just how national data is probably collected and reported, and how networks are supported. So important that we continue to focus on it, as we've said. I just wanted to ask for Dave and or Luke or anyone else really, just the one area that I was interested in hearing a bit more about was students. I know it's referenced in the report, and just kind of how we hear, because in LPT, we have Liz Anderson, who colleagues will have met, who is who's a NED from the University of Leicester. And I think there's a bit of work that she always talks about, the importance of the student voice, which I know we recognise, but students sort of come and go, and they have a particular perspective that they can give us, whether it's medical students or others who are on placement. But supporting them to speak up whilst they're with us is probably quite challenging. And I know LPT colleagues have been trying to do sessions working with the university. So I just wondered whether there's anything Luke, that we're doing, and whether we need to think about that sort of approach if we haven't already.
I definitely think that's something we need to think more about doing. I would say that we aren't doing enough in reaching out to again the universities and getting this at an early stage. So I am in a unique position in that I cover the role over UHN as well, and we're already looking at getting involved over there with the universities, University of Northampton. So that's an area that I can bring both sides of my roles, including NHFT too, as a starting point. But yeah, definitely we've seen from the staff survey results, student confidence in speaking up has dropped, and it's on our radar to address and look at how we can engage more with our students.
Yeah, thank you, Luke. That's really helpful, and I think it's interesting to explore. I think Pauline, one of the Guardians over in LPT, actually goes and does session, actually speaks to students on training. So I just thought that was quite an interesting initiative, because it might help just to encourage people to use their voice whilst they're with us. I can see Richard wants to come in to add to that, a perspective to that, I suspect. Richard.
Thank you, Krishni. Yes, the Professional Practice Education and Training Team, PPET, has regular liaisons with students, just try to encourage them to give them avenues to feedback on their placement experience and overall how they feel, accepted, hopefully within NHFT. So there's that work. So you might want to link in with us, Pipette, Tracy Dodds or Sharon Allen would be your contact person. We do try and create avenues for students to share and feedback the experience of being part of our trust, whether on placement or generally. And so yeah.
Great. So there might be a couple of opportunities, Dave and Luke, we can explore just to sort of try and encourage that, Luke, because it sounds like an area that we can certainly strengthen. So thank you very much. I think it's a really helpful report, and I know there's sort of regular other touch points as well. And Luke, we look forward to doing the reflection tool in due course, because I know that's a really important element as well. So thank you. Welcome on board. I know it's still relatively new for you, isn't it, Luke? Is it a few months that you've been on board? But really great to have you, and really great to have you working with Beth, I think, as well. Any final comments, Dave?
No, other than to thank Luke for joining the team and supporting Beth, who's had to take some leave for family issues, and it's just been fantastic to have that coverage across the whole working week. So many thanks to that, and many thanks to colleagues who have spoken up. It really does enrich our ability to deliver safe services.
Brilliant. Thank you very much, Luke, and we'll see you again through the regular touch points we have in place. So, and thank you for the report. Okay, we'll move on then to the final couple of formal items on our agenda. One is the EPRR report. This is one of those big mouthfuls, isn't it? The Emergency Preparedness, Resilience and Response report, paper P. And if you want to cover any specific points before we open it up.
Yes, thanks, Krishna. Yes, it's quite a mouthful to a report title, but thank you. So this is the annual report. I think one of the couple of points I pick out. One is that the biggest change for this service at the moment is we've now got a shared group team, which has been a fantastic development, so much learning, and also just sort of aligning how we're working. Which has really helped, particularly when you think about industrial action or incidents and being able to support each other. So that's been fantastic, but it's meant we've had to change some of our sort of planning and reporting to sort of align up, which has been a useful exercise. One thing that we have done this year is ensured a good link into the operational oversight meetings so that we pick up any EPRR sort of issues and actions operationally very quickly. So that's been good. We have good oversight through the EPRR steering group, going to a lot of detail around features around training and awareness and learning, and all of that's fed up to quality and safety on a regular basis. Training is a massive part of the programme of the team, particularly around our on-call directors and managers on call. Obviously, this is like but you never quite finish it because there's always someone new coming online, but it's our on-call system is an integral bit of how we work as an organisation, and it's so important to make sure that people have the training and support they need to fulfil those roles. And we are in the process of updating our sort of information for managers for winter. As you'll see, there's lots of exercises. We've led quite a lot of that internally and externally, and the team have excelled well in that. And we've got a growing picture of business continuity. Had a really live experience the other day when we had a power outage that actually there's always learning and always new things to consider, and that reflective cycle enables us to continually build our business continuity plans. We just had really it was good for the team to see a really live experience of that in the last few weeks, and how they responded to it and updated the business continuity plan for future. So I think that's about it. This is obviously a part of our core standards submission that this board and the committees are cited on this annual report.
Thank you, Anne. Any questions or comments then on this? Julia?
Thanks, Krishni. Just a comment, just to add to Anne's comment about this. This has oversight from Quality and Safety Committee. We are always fully assured by the information that comes through, and we look forward to looking at the core standards in a bit more detail. But actually, just to remind people, this was an area of outstanding that we highlighted last year, because from the annual assessment, there was a huge amount of work undertaken, and at the peer challenge review session that you undertake with system partners, we did exceptionally well. So hopefully looking forward to that again this year. Thanks.
Thank you, Julia. Jo?
Thank you. I was just going to point to the amount of training exercises which Anne landed on, because in a previous life, this was something I spent an inordinate amount of time getting very close to. And I think just to commend the management approach to this, it's really, really positive, particularly the value that's being placed on external exercises, because it's one thing to be able to control our own agenda, but it's given me a lot of confidence to read about the extent of the external activity as well. So thank you.
Thank you, Jo. Indeed, I think it's a really comprehensive report. I think the only thing I just wanted to explore around was just the table which showed what I think was described as the overall compliance of each directorate against the business continuity KPIs, and the compliance rates didn't look brilliant, I suppose, dare I say. They didn't look like they were at sort of levels that we might want in all cases. So but I just want to check if I've understood it correctly, because, for example, it says adult community services 49%. That may be misleading, so I just wanted to double check my understanding of that.
Absolutely, and this is part of the business continuity is an ever-growing process. So we've got assessments for every service. It's then those bespoke business continuity plans, which is the growing picture with the core standards. So there's some services that won't need to have a bespoke business continuity on certain sections, but it's that constant review of what we've got, and you should see that grow, and also to us to have more business continuity plans. So, for example, the other day we've got really strong business continuity plan of for IT. But that was when we had a situation the other day, it was like that we'd done that for on-site and actually what happens out in the community. So we were able to develop that plan even further. That means you've got an additional plan to write. So it's like a constant iterative process. So I think it's important that we see it's constantly changing, but that we've got the oversight in the EPRR group with the underpinning details. So they're the ones who've needed to have them put in rather than that they're not working on them, if that makes sense.
Yeah, that does. Thank you. That's really helpful. And good to know that it has constant oversight. So thank you, Anne. We are, I think, only required to note this, aren't we? I don't think we are approving it, or are we? Are we approving it as an annual report? I think it's the first time in a while we've had a formal annual report, hence my slight let me just check. To accept and approve for our core standard submission. So is everyone happy to approve on that basis? Thank you. Finally, then, we have our AAA report from the Audit and Risk Committee. Duncan, over to you.
Yes, thank you. I'm pleased to report that there are no items for alert, no items for advise. Under Assure, we had a good presentation on anti-crime. There are two items within that report which were assessed at amber rather than green. That's a statement of actually just how well things are going. For both of those items, there's work well in progress, and it was really a matter. It's too early to start saying they were green rated. The Seeker report from TIA our internal auditors. It was really pleasing to hear that there were no recommendations overdue. So really thanks to everyone, all the management leads who've been receiving these recommendations as auditees. Many thanks for that. I know it sounds like quite a back office and dull and boring audit thing, but it is a real achievement to Anne and colleagues that they're absolutely up to date and listening to the advice that's coming from our internal audit service. The self-certification, which you see in the pack, the board actually has considered on the 29th of May, so I won't dwell on that. But finally, on the Assure, the external auditors also gave us great assurance that there were no significant weaknesses. As we discussed earlier in the meeting, however, they brought our attention to the non-recurrent nature of savings last year, and we're seeing that again in Paul's report earlier in the meeting for this year. I know I've said finally once already, Krishni, but this is it's unfamiliar territory for me in the Audit and Risk Committee to move into celebrating outstanding, mainly because we don't like to get there too early. But I think we took some time actually reflecting on the work that Paul and his colleagues in the finance team, but actually it's a whole team NHFT element of success in getting ourselves a really good audit report coming in from Grant Thornton and our auditors, and we really thought we'd celebrate that. I know formally we do that in public at the AGM, as you highlighted earlier on to us on the 15th, but Paul takes the lead for this stuff and quite rightly gets the plaudits of the audit committee at this time of year for a job well done, but also he's the first to say it's a team effort and there's so much work across the board for it. Thank you, everyone.
Thank you very much, Duncan. Any questions for Duncan or any points that any members of the audit committee want to add? Actually, I omitted to say, I think we had a significant assurance on our Freedom to Speak Up processes, did we not? I'm sure it was reported in the ISA 260 meeting that the internal audit opinion summary showed that as something that had significant assurance, which we must note because it is really important that that was the case. I think I've got that right, but if I haven't, then I stand corrected, but I think I mentioned it at the ISA 260 meeting. Thank you very much, Duncan. Really good to note. And obviously we did have the ISA 260 meeting in the meantime, and so we saw some of those reports, so thank you. We have the board declaration of interest register available for noting. Obviously don't need to go through that, but it's there in the public domain. So we have a few minutes. I have no other business that I particularly have been alerted that I need to pick up. So we've obviously concluded our business more or less on time, but just want to double check. Was there anything that in our discussions that alerted a new risk that we hadn't considered before? Were colleagues content that the agenda was appropriate and we gave due attention to things that were needed? So if there are any items of feedback, you are most welcome to note them quickly, or I can just let you go to lunch. Julia.
It's not an item of risk. It's just to say that the patient story, thanks to Anne and to James for bringing that, because it was a great start. Look forward to the future ones from each of the directorates. So really good start. And thanks to Barry for agreeing to be filmed. Thank you.
Thank you. Yes, really good, because that is sort of a new sort of adjusted way of doing it, which we discussed I think previously, so really helpful. And have you already thought about who's next on the, or which pathway is next?
Yes, we've sent out that it'll be the mental health and learning disability and autism pathway next, yeah, James set the bar. So we've sent on and said we want to jump past this next time, but no, I'll take all the feedback we've had here to inform getting that one ready.
Lovely, thank you very much. No, it was a really interesting, and we probably need to allow more time for it at the beginning of the meeting. That's probably my one reflection, so that we don't curtail the discussion. So thank you, everybody. Thank you to all the colleagues who compiled reports. Always challenging, I know, and I think we heard some really positive things, as well as some of the challenges we are grappling with, which is completely appropriate for our public meeting. So I will bring the public meeting to a close.